you'll see it's red. Red light comes on, and now you're live. And then when you're done talking, and the light comes on, and then you're live. And the red light comes on, and then you're ready to go. And when you're done talking.
Red light. Okay.
And then when you're done.
Good morning. I'd like to call this meeting to order for the House Study Committee on Improving Access to Internal Medicine in Underserved Areas. First, I want to thank each of you for being here today, for your expertise, for your time, and being part of this process. The purpose of the study is to conduct a thorough and thoughtful examination of internal medicine and to understand the challenges and the opportunities and to consider recommendations that will make a meaningful difference to our state. I want to thank Georgia Southern for the hospitality of helping us kick off our very first meeting. And I also want to thank our staff, Mr. Leo Chauncey, Senior Political Analyst, and Ms. Cameron Sanchez, our Committee Assistant, for organizing this meeting. Finally, we want to thank Mr. Justin Speck and the House Media Services Office for their support. We'll be hearing from experts today and having opening discussions among members. And I want to encourage each of you to be candid, to be constructive and focused on our solutions. Our charge is not only to study the facts, but to listen so that any recommendations we make will be reflected to those most affected. With that, let's proceed and introduce ourselves. Members, if you could state where you're from, as well as what you hope to accomplish through this study. And I'll start off. I am from District 105. I'm Sandy Donatucci, and I am from Gwinnett County. More specifically, I have Decula, Lawrenceville, and Beaufort. I expect through this committee that we will find strategies that can improve and deliver health care so that regardless of the location, we can provide for Georgians. Gary?
Good morning. I'm Gary Richardson, District 125, serving part of Columbia County and McDuffie County. I again want to thank Georgia Southern for what they are doing and hosting us. I was down here in the 70s, and it's changed a little bit since back then, but what a great facility and what great things they have going on down here. So, you know, being from Augusta, and we don't have a problem with medical in our area. From my house, there's 4 hospitals within 30 minutes or less. So I don't really understand maybe, and I think there's a lot of people that don't understand the need of what we're talking about and what we need to figure out. So what does underserved areas look like? Is it a lack of medical facilities, a lack of medical staff, lack of transportation to care? So, and what level of improvement does it take to be in an improvement and to make a difference? So I think we're tasked for a big challenge, and I'm looking for some positives to come out, because we come out with some good things here and we make some progress that affect that people want to go to rural parts of Georgia to live and raise their families. So, thanks.
Okay, now I've got it. Thank you. I'm Lisa Hagan. I represent House District 156, which is 6 counties just south of here. And I also chair the Rural Development Committee. And so as as a member and as the chair of that committee, I'm interested in all aspects of rural development and how we grow our rural communities and strengthen them. And obviously, access to quality health care is at the top of that list of both concerns and priorities. So I'm very thankful to be a member of the study committee, and thankful to all of you who are here to help dig into what the realistic current situation is with healthcare in rural Georgia and as our state as a whole, but also to look at what unique opportunities we have to be creative in the way that we meet the needs of our constituents. And as Georgians, we obviously have a much more sparsely populated area, so we have challenges. But I think that enables us to get creative in how we rise to those challenges and meet the needs of our people. And so that is my hope here with this study committee, is that we will dig into what the current situation is with healthcare in rural Georgia, but also start to look at what are some of the options of how we meet those challenges. And I believe there are solutions. We just need to get to the bottom of them. So thank you for chairing this committee, and appreciate being here with y'all today.
I'm Jean Sumner. I'm the Dean of Medicine at Mercer University School of Medicine, and we're a school that is committed to rural health, and we take our mission very, very seriously. More importantly, perhaps, I'm an internist, and I spent my life in a poor rural county till I went back to Mercer about 10 years ago. I do believe there are solutions, and I really appreciate the state and the committee looking at what they are and how we can help. So much of the cost of care comes from chronic disease, and much of that chronic disease could be diagnosed early, controlled, treated, prevented, and particularly in rural areas where there's no access.
Hi, I'm Angie Gerges. I'm a family physician here in Statesboro. I've been in Bullitt County now for a quarter of a century. That sounds kind of long, doesn't it? And our area is very unique here, and it's been a wonderful place to practice medicine. We have great educational opportunities here with Georgia Southern and Ogeechee Tech and East Georgia College, all of those. We also have a significant rural and agricultural component, and quite a bit of poverty too in this county. And seeing all that disparity is very frustrating as a physician, because the problem is big, and we see problems and we know what kinds of problems there are, but we, to our detriment, we bury our heads in our work and we just keep plugging along, and we don't do the things we need to do to let the people know who can make the changes that can help us be able to help our patients. And with 41% of our Georgia population lives in rural areas, but only 7 to 8% of our practicing physicians live in rural areas in Georgia. And so that's a huge issue. Medical schools are so important to increase the number of graduates that we have. We need more residency spots. We know that people tend to stay in the state that they do their residencies in. And if we can garner those people very early, start talking to them in high school, get at them in college, really have good, robust pre-med programs, really work hard to get as many enrolled in our medical schools and as many spots as we can, and the same thing for residency programs. It's huge importance for our physician workforce and our healthcare workforce just in general. But particularly in rural areas too, we have our social determinant of health problems with poverty, with transportation, with broadband access service, all those things, which really complicates the issue and just it makes it very hard to manage. So I'm excited to hopefully be a part of this and hear from an interdisciplinary kind of team to see what we can do to help come up with some hopeful answers.
Hi, I'm Darlene Taylor. I represent District 173 in rural southwest Georgia in Thomasville. I'm very grateful to be here today and to be able to hear everything that's going on. The healthcare issues that we have in our state are not unique. It's across the country. I serve on the appropriations and I focus on healthcare, so it has a special meaning to me to see what we can do. Access has many meanings. You need access, you need to have the physicians available or the provider of the care that you need. You need to have transportation to get there. Is there access? We often have people tell us in South Georgia, we'll just call Uber. We don't have Uber. We also need that, be able to pay for it. You can't bring doctors to Georgia and then not pay them. If you build this wonderful medical that we're doing, we need to build it, they will come, but if you don't pay them, they ain't staying. We've got to look at those and make sure that everything is covered in these pieces. So I'm excited to hear the things we're doing, and I have to tell you, I really agree that the chronic disease management is going to be key to helping everyone. If you start out getting people through your internal medicine, family practitioners, keep your patients healthy, it helps in the long run. So I'm excited about what we're going to hear, and I look forward to it. Thank you.
Good morning. I'm Butch Parrish. I represent District 158. I live in Swainsboro, and I represent Emmanuel County, Truitland County, Candler County, and a portion of Bullock County. I'm delighted to be here with this group today, and we're all about trying to increase access to quality, affordable health care. And we've done a fair job over the years, but we've still got an awful lot ahead of us to do. And all the things that have been mentioned here and the challenges where we are unique sometimes to where other folks are in this state. And I remember the story about the Uber when we were talking about non-emergency transportation for Medicaid one time. One of my Atlanta friends says, well, we don't need to fund that program. They can just take MARTA. And we said, well, we don't even have a taxi where we live. So the problems are unique. And we've done a good job with addressing some of those, working with our partners like Mercer. Nobody understands rural health care needs better than Dr. Jean Sumner over there. She was rural health care before it was cool. She's been doing it a long time. And Madam Chair, you got the right folks on your committee, and I look forward to hearing the information that will come out of this committee and possibly the recommendations that will come from your committee that we can take back to the legislature and look at how some way to address some of these issues that we see as problems with potential solutions. Thank you for allowing me to be here.
There we go. I'm the caboose. My name is Angie Osteen, and I represent District 169. That is Coffee, Irwin, Turner, and Tift. So most of Coffee and a little bit of Tift and everything in between. So I'm from a rural area. I'm actually a nurse. I haven't practiced in several years. I've been volunteering and trying to stick my nose in a lot of different things to figure out what makes our communities work. I am grateful to be on this committee because I have a child that wants to be a physician one day, and so either a physician or a CRNA. She hadn't quite made her mind up just yet, but I appreciate Mercer's mission to educate rural students and sending those people back to rural Georgia, because I agree 100% with what you said. We have got to increase enrollment of students from these rural areas because and catching them early is important. I just heard a statistic yesterday. I met with UGA veterinarians, and they said that by the time a student is in 8th grade, they know whether or not they want to be a veterinarian. And so they're trying to capture them early, get them on a track. And the same thing, I think, would go for healthcare. A lot of times people know they want to go in medicine. They might just not know which field they want to go in, but capturing them early so that we can get them seated in schools so that we can meet the needs of rural Georgia. I think it all starts with the right education and getting those people in the schools. So how we can increase enrollment so that we can meet those needs. I just found out some things that are going on in my district that I did not even know about yesterday, thanks to Becky's organization of people, and that's meeting the needs that maybe we can help build upon that too. So looking forward to it.
I'd like to welcome Dr. Avi at this time. He is the Provost and Executive Vice President of Academic Affairs and he just began in July, so I'm so excited to have you here. And you are a fellow Pennsylvania person,
right.
so I
Yeah.
have to say hi to that as well.
Thank you very much. Well, good morning, everyone, and thank you for being here. Welcome to Georgia Southern University. As you heard, I'm Avi Mukherjee. I am the Provost and Executive Vice President for Academic Affairs here, and I started in July, relatively new in this position, but I have been a Provost before at Marshall University, serving rural communities with a medical school there in the West Virginia, Ohio, Kentucky, and Pennsylvania areas. So very much kind of conversant with the challenges we are talking about and very passionate about it as well. I am by training a professor in the area of business, and my area of expertise is actually healthcare management and administration. And so this is particularly interesting to me that we are assembled here to discuss one of the biggest challenges that we all face as Georgia becomes a more prosperous state with more industries and more investments. How do we keep healthcare improvements along the way so that we can have more people live healthy lives? Well, on behalf of Georgia Southern University and President Kyle Marrero and our entire leadership, on behalf of our faculty, staff, and students, it's my distinct pleasure and privilege to welcome you all here today. This is a great group, and we are incredibly proud to host this important committee on improving access to internal medicine in underserved areas here at Georgia Southern University. Before I begin, I want to extend a warm welcome to Representative Sandy Donatucci. Thank you for being here as the chair of this vital committee, and to all the distinguished members of the House of Representatives joining us today. I would also acknowledge the support of House Speaker John Burns. Your collective commitment to addressing the critical healthcare needs of the state is deeply appreciated, and we are privileged to support your important work. Your work, established by House Resolution 753, is not just about policy, it's also about improving the daily lives and health outcomes of countless Georgians. I want to extend a special welcome to our committee members, Dean Sumner, Dr. Odom, and Georgia Southern's own Dr. Gurgis for our medical expertise in this area, and of course, again, Chairwoman Donatucci, Representatives Osteen, Hagan, Rice, and Richardson for your presence here today. I want to talk a little bit about Georgia Southern and talk about what we are doing in the area of healthcare that is so exciting and I think can really help in this particular project. But I'll start first by saying that today is an exciting day to be here at Georgia Southern University. It's the first day of our academic year. It's the first day of our fall semester. And you probably saw the energy as you arrived on campus and probably a lot of traffic with students trying to figure out where to go. It is an exciting day because we are hosting and celebrating the largest freshman class in our history. Thank you. Thank you. It's a great work of everyone on this campus and, of course, the support of the University System of Georgia and the entire Board of Regents and the state and the legislature for helping us to be there. We are looking at 6,000 freshmen and over 30,000 students across our campuses in Savannah, in Hinesville, of course, Statesboro, and soon to be added, Swainsboro. 89% of our students are from Georgia, so you can actually see how important a role we play in furthering the future of the state. A lot of our students also continue to live and work in Georgia. So Georgia Southern University is a university that is in the state, it's rooted in the state, and it keeps our graduates largely in the state, which is exactly what we are talking about here. It's extremely important that we have a state which can retain its own people and really produce the workforce of the future. You know, when we talk about healthcare, one of the things that I particularly have seen, and which is exactly what we are all talking about, is this whole aspect of healthcare disparities, of the need for family and internal medicine to go deep into the rural areas of the city, the state, and the region. We need to have residents and fellows that come and work here and continue to live here. We want the best physicians to be here, and there is always a shortage of physicians. So one of the big things for us is to create an ecosystem that can expand medical care, not only with physicians, but supporting healthcare, allied health professionals as well. So I want to mention a few things that we are doing in that regard as to how we have brought everybody together across our 10 colleges, across our 45 departments, and about 150 academic programs to create a healthcare footprint across the state. One of the things that we really believe is important for us is how do we create interdisciplinary clusters for university excellence. We have, as every institution has, a lot of faculty across the university working on a large number of different projects, teaching different classes, and what we are right now trying to do is to create these interdisciplinary centers of excellence that combine the resources across the university and make a real impact in the region and the community. So I want to talk about 3 of those here today, and these are holistic, these are, as I said, distinctive, and these are transdisciplinary. These areas will help us create innovative programs, secure large funded grants, and build impactful corporate partnerships and regional projects. Now, some of these, and there are 6 of these, one is on AI. We are really doubling down on AI, as everybody is. We have one on cybersecurity and forensics, and one on coastal sustainability and resilience, being a coastal community. But the 3 I want to talk about today are vibrant rural communities, biomedical and health innovation, and advanced materials, mobility, and movement. Let me start first with vibrant rural communities. And this is exactly what we are talking about here today. Healthcare is the basis of a thriving and vibrant rural community. This interdisciplinary cluster that we have formed directly addresses the socioeconomic and health challenges that define our underserved regions. Our wide range of initiatives, from interdisciplinary research to community-driven projects, focus on building a stronger and more resilient community through collaboration and innovation. One of the things that Georgia Southern is particularly good at is not to keep the education in the classroom and the labs, but to take it into the community and the region. We believe in offering classes and education that go beyond the academic sphere into experiential learning and project-based learning. We are also a big believer in combining teaching with research and in combining access with excellence. All of these things define who we are. We are not a pure research university. We are not a teaching-only university. We are one of those very few universities that do the 2 things together and really bring in students from various spectrums and various backgrounds into the university and help them to succeed while seeking excellence and distinctiveness. So a key part of this vibrant rural communities cluster is our Center for Social Gerontology. And I'll talk about that. It was established in 2013. Its mission is to make a positive difference in the lives of aging individuals and their families and communities by increasing awareness and supporting the needs and activities of diverse older adult population. The Center for Social Gerontology it grows into a thriving community, including faculty, staff, students, elder service providers, and older adults, all committed to understanding and improving the aging experience. We know that when we are looking at gerontology, we are looking at medical solutions, including physicians in this area of geriatric care, but also supporting health systems that support the geriatric movement and the need for professionals in the area of internal medicine and family medicine to address this important need. A flagship program under the center is the Senior Companion Program, which addresses the critical need for in-home support for older adults. This program pairs community volunteers with older adults and people with disabilities who need additional support to remain in their homes and live independently. These dedicated volunteers provide crucial services such as supervision, assistance with light chores, limited transportation, and help with meals, while also offering much-needed respite for caregivers. The program serves 9 counties in Georgia right now, and will expand from there. Our College of Behavioral and Social Sciences also offers an interdisciplinary minor in gerontology, which provides students with experience in aging care with nonprofit sector, state government, healthcare providers, and so on. Another vital component of our vibrant rural communities cluster is the Center for Public Health Practice and Research, which is housed in our Jingping Su College of Public Health. This center is a national leader in translating public health research into actionable practice, eliminating or addressing health disparities in rural communities and underserved populations. They are working on a lot of different projects. For example, recommendations for operational efficiency for rural hospitals and emergency management services, assessing how managed care organizations address the social determinants of health, including Medicaid populations, and evaluating the public health workforce needs and training. The center offers high-level technical assistance and has secured $6.4 million funding, producing over 200 technical reports and working with more than 100 rural hospitals nationwide, engaging every health district in Georgia. Their key projects include the Georgia CAH Community of Practice, the Rural Hospital Board Training Leadership Program, and the federally funded Targeted Technical Assistance for Rural Hospitals, the TTAP program, all aimed at strengthening rural health infrastructure and leadership. Additionally, we have a Center for Addiction Recovery that is growing as one of our big assets here at the university, providing supportive environment for those recovering from addiction and engaging in research to improve treatment, particularly in rural communities. We also have the Magnolia Coastlands Area Health Education Center in the Waters College of Health Professions, which contributes to recruiting, educating, training, and retaining a diverse health professional workforce across a 39-county service area in Southeast Georgia. So when we look at just this one college, the College of Health Professions, which is our largest college at the university, and when we are looking at other health programs across the university, we are looking at a large variety of options that support the medical and the dental school that we are talking about on our campus in Savannah, coming up with the Medical College of Georgia. And those supporting ecosystem includes our programs in nursing, in radiology, respiratory therapy, medical lab science, physical therapy, medical imaging, public health, epidemiology, biostatistics, biomedical sciences, healthcare administration, nutrition, kinesiology. We have some CPE continuing ed programs in areas like pharmacy tech and health informatics, which includes telemedicine, which is one of the topics I believe we are going to discuss later today. So it is a wholesome training program that we have to support the entire healthcare ecosystem in the state, all the way from physicians and dentists, all the way through nurses and allied health professions. And we want to continue to grow in these areas. These are really important as we fill critical gaps in primary care, in emergency medicine, and in public health initiatives. I also want to highlight our biomedical and health innovation cluster, which is another of the three clusters I talked about, which focuses on leveraging technology and data to create innovative solutions for healthcare access and outcomes. A number of colleges are involved in that, including our College of Science and Mathematics and our College of Engineering, by talking about devices, supporting physicians, veterinarians, pharmacists, researchers, dentists, forensic scientists, into creating wholesome solutions for medical innovation and technology. An example of that is our work on the Institute for Health Logistics and Analytics. And this is something that has really been improving global health through evidence-based practices and technology integration, using supply chain as an example and logistics as the principle, using a One Health approach. One of their most groundbreaking initiatives is the Health Kiosks in Rural Georgia project. This project is designed to put medical supplies and easy-to-access vending machines, effectively bringing healthcare resources into underserved communities where traditional clinics may be scarce or difficult to reach because of transportation issues. The College of Public Health also contributes to the Biomedical and Health Innovation Cluster with the Carl Peace Center for Biostatistics and Research, which provides large-scale epidemiological and biostatistical work related to health-related studies. We all know how important this field is in the era of growing epidemics and all the concerns that we have, but also in being able to project the health status of individuals. Thirdly and finally, I want to talk about our Advanced Materials, Mobility, and Movement Cluster, which talks about the fact that we are really in the business of improving transportation options. We just heard that today, and we will hear more of that in Georgia's rural communities. You know, when we work with our College of Engineering, College of Business, and various other colleges across the university, we are really looking at improving solutions with robotics and intelligent operation systems, again with telemedicine, with advanced power and energy solutions in the area of healthcare, and really providing healthcare services at home and in the areas where we can reach. A lot of this work is related to our new PhD program in material science that is being developed at Georgia Southern, integrating chemistry, physics, and engineering with health sciences and medicine. The goal is to provide innovation in advanced materials and nanotechnology in providing solutions in medical devices and electronics. Again, all these things are being worked out with corporate partners, with regional partners, partnership with our health systems and community engagement, as well as with companies like Hyundai Motors, which, as you know, is very interested in addressing logistical and infrastructural barriers served by underserved populations in this region. So in closing, I think Georgia Southern is committed to be a strong partner in providing health solutions in a holistic manner to provide solutions for health disparities across our state. How do we integrate health solutions with technology, with public health, with engineering, with business and healthcare administration is really been the focus of this university. We are proud to be a healthcare leader in education and solutions, leveraging our resources across the entire campus and across our 2,000 faculty and staff that are working continuously to help and support the region. So as a university, we stand ready to partner with the State House Study Committee as you continue your vital work. We believe that combining policy innovation, by the way, just yesterday we approved a new undergraduate program in public policy through the Board of Regents, and that is the kind of work that can bring everyone together. We want to combine policy innovation with practical evidence-based solutions in public health from institutions like ours. All these interdisciplinary efforts are supported and informed by the direct involvement of our world-class faculty and staff at in-state initiatives. I would like to specifically highlight Dr. Angela Gurgis, our Medical Director of Georgia Southern University Student Health Services, who I'll call upon to say a few words, but let me first provide a brief introduction of her. Dr. Gurgis brings a remarkable depth of experience to our university and the state. She earned both her Bachelor of Science in Biology and the Bachelor of English degree from the University of Tennessee at Knoxville, and a Doctor of Medicine degrees from the University of Tennessee College of Medicine. She completed a residency in family medicine at the University of Tennessee Medical Center and began private practice in Statesboro in 2000. For 5 years, she served as the medical director of the Ogeechee Area Hospice, holding dual board certifications in hospice and palliative medicine, and then joined Georgia Southern Health Services in 2018 and was promoted to medical director in March 2022. Dr. Gurgis is not just a leader within our university, she is contributing to shaping healthcare policy for the state and is one of the non-legislative members on this study committee. She was specifically appointed as a licensed healthcare provider familiar with the needs of rural Georgia. So someone whose experience we deeply value within the university in terms of guiding our project, our research, our academic footprint, and so on. So as I finish, I do want to mention that we are a university that is committed to collaboration, that is committed to regional engagement and economic development, that is committed to public health and wellness, and that is committed to interdisciplinary research. All these things make a comprehensive public university like ours thrive in today's world, and we are committed to support your work in every single way possible. So again, thank you for being here. Thank you for discussing all these topics that are some of the most important topics for us today. I'll be happy to take any questions if you have at this point, and then right after that, I would invite Dr. Angela Gurgis to come here and say a few words.
Any questions? Okay.
Thank you very much, Dr. Gurgis.
Well, good morning. I don't know that I have a whole lot to add to all the wonderful things that Dr. Alvey talked about. I guess I can kind of just highlight that, first of all, I did all my training in Tennessee and grew up in Tennessee, and always thought that if I was going to live anywhere other than Tennessee, it would be Texas, and I wound up in Georgia. So, so Georgia is an amazingly well-run state. Having been in other states, I can see the difference and the dedication that the people who run this state really do have to try to make it the best state in the union. I think that we have some exciting possibilities. I first went to Baxley for a year before I came to Statesboro. I got married and came to Statesboro. And in Baxley, at that time, the city had 3,500 people. There were, I think, 5 physicians. There was 1 OBGYN, a couple internal medicine, a pediatrician, and a surgeon. And then I came in as the only family medicine physician. And it was scary. We were in Baxley, you really are kind of far away from everything. It really took a lot of effort to get somebody to Savannah or to Augusta or to Jacksonville. You know, it was difficult. And I had to call on a lot of our specialists, which back then we didn't have telemedicine, so it was just a phone call, you know, with my patient in my office. And when I came to Statesboro, it was more people, more resources, but even in spite of all that, it still was lacking. We had a lot of patients who were underinsured, not insured at all, didn't have transportation, didn't have money to get their medicines. We didn't have the specialty resources that we needed to manage the diabetics, to be able to have nutrition counseling for people. I mean, it just had we have a lot of issues with that. And it's better. And for 18 years, I was a townie here, and I lived in Statesboro, and there was the college, and the college was over there, and the rest of us were over here. And that's really kind of how the city and the medical community kind of looked at it. My predecessor, Dr. Brian DeLoach, came in maybe 2005 as the medical director, and he absolutely transformed student health services here. It is amazing what he was able to accomplish. And we have a state-of-the-art facility. We have physical therapy. We have dental now. We have women's health. We have lab. We have x-ray. We have just all kinds of things. It's an amazing place to be able to practice, but also to see what can happen when you have a forward-thinking mind on how to reach people. I'm very interested in harnessing the exciting, amazing ability of these young people and these professors in our institutions to help move us forward and to be able to spread our fingers out into the rural communities, to be able to access patients and physicians for research to work with the universities, because that really just doesn't happen. In private practice, you rarely do any kind of research, and it is scary. It is a lot of regulation, and you don't know what to do. But there's so much that could be done, and patients could absolutely benefit from that. They're not being guinea pigs. They're getting the first line innovation first, and we really do need that in rural Georgia. I'm excited to get to be a part of this and hope we find some really innovative solutions. We're very excited for y'all to be here at Georgia Southern, too. We want to show everything off. Like you said, we have the largest class we've ever had. We have the largest freshman class we've ever had. If there's a lot of buzz out there, I told somebody earlier, when you're going to turn right, you always have to look in your rearview mirror, because they're going to come zooming through on their bikes or their scooters. And those scooters go 17 miles an hour, and they don't have to wear helmets. So please watch out for them. Thank you.
Thank you so much. So at this time, we'd like to welcome Becky Riles and her team.
Madam Chair,
Oh, excuse me.
Before we do that, could I, with your permission, introduce a guest in the audience who's with us, who
Absolutely.
lives in this area, Senator Billy Hickman. Billy is a champion for education and health care, and he's here with us today, too.
Okay. If we can welcome Becky Riles and her team up to the front. This is going to be for federally qualified health centers.
All right, good morning. Thank you, Madam Chair and members of the committee. I am Dr. Teresa Jacobs. Hey, Dr. Gerges. She and I sit on another committee for the Georgia Academy of Family Physicians, and I am the clinical director, the medical director for the Georgia Primary Care Association, and we are going to talk about what we do as an organization. Just before I do that, though, just to tell you quickly, just a little bit of my story is that, probably almost 40 years ago, I found myself married with a newborn, and unfortunately, my husband came home and said, "Love doesn't live here anymore." And so after the divorce, kind of went through a period of time trying to figure out what I was going to do with my life, and so this single parent decided to go to med school. And while in med school, as back home at Michigan State, because I'm from Detroit, a native of Detroit, I did an elective because I didn't know as a med student what I wanted, what kind of doctor I wanted to be, and I did an elective at a community health center down in Atlanta at West End Medical Center. And I tell this story because a lot of folks will understand, especially if you're from a big inner city from Detroit like I am. When I went out one day for lunch, a gentleman opened up his coat and he had jewelry and rings and all, and he said, "My sister, can I help you?" And I simply said, "I'm home." And so since then, I have been working in a community health center for over 30 years. I am one of those individuals that absolutely believes that she was born, created to work as a family medicine doc at a community health center. So I work, play, worship, and live in the area that I serve. So I want to thank all of the legislators and all of the community health centers for helping me find my place in life. So as I move on and say that, the Georgia Primary Care Association and the FQH system, we are the Georgia Primary Care Association. We are a member service organization, and it is all of the FQHCs, or the federally qualified health centers. They are part of our organization, and we offer them technical assistance, planning strategies. One of my main jobs is to train all of the clinical staff, the workforce, how things, what they can do better, any new things, innovations that come along. Part of our job is to make sure that our health centers, or the FQHCs, are in the know of the latest and the greatest. And so what are FQHCs, or community health centers? We are organizations that receive grants under Section 330 of the Public Health Service Act and other certain tribal organizations and FQFCs lookalikes. We are local, we are nonprofit, community-owned healthcare providers serving low-income and medically underserved communities. What are FQHCs? In addition to what I just said, they're local, nonprofit, community-owned, serving low-income folks, medically underserved communities. We are cost-effective, reducing the cost, avoiding patients from going into those emergency rooms, especially if they have a health center right in their community. It stops or prevents them from going into those emergency rooms, therefore cutting down on costs. We have, as an organization of FQHC, saved the healthcare system well over $35 billion a year because of the care that we give our patients. FQHCs are open to all residents, regardless of their insurance status or their ability to pay. As far as charges, if you're uninsured, we are on a sliding scale based on what the family can pay. And because of FQHCs, we have a number of civil rights activists that are helping us to take care of these folks that are in these low-income communities, and we've been doing it since the 1960s. For the past 60 years, the national network of nearly 1,500 FQHCs have provided high-quality, affordable primary care and preventive services, and often provide on-site dental, pharmaceutical, mental health, and substance abuse services. This is us in Georgia. You see the map. We're actually in 140 counties. There are only 169, and we're endeavoring to be in all of the counties. There are 36 FQHCs with over 330 sites. Last year alone, we saw over 740,000 unduplicated encounters or patients in our health centers on last year. So this represents a growth of 100% in the number of organizations and 150% in the number of clinic sites over the past 15 years. these are all of the FQHCs. They're listed by name, and we can also make this map available so you'll know where FQHC is in your community. The other thing I would love to let you know is because we are federally qualified health centers, we are mandated to report quality measures. In FQHCs, we do extremely well. We do better than most private doctors' offices. Over 80% of our diabetics, those patients that have the diagnosis of diabetes, they are considered controlled. We do depression screening started at 12, and we do that consistently as part of our workflow. We discuss BMIs, diet, and physical activity at almost every visit. The patient comes into our offices, and so we have to do it because we're mandated to do it, but it's just good patient care to make sure all of our patients are, we are hitting those quality measures. It improves health. It makes patients that ordinarily wouldn't see a birthday, they get to see that next birthday. They get to celebrate the graduations, the weddings, and so we are proud of what we do at the community health centers. Here we also have school-based health centers throughout the counties, and you can see that on the map above there. We've got some that are being developed, and that's the gray areas that you see on the chart, on the map, and we're very proud of that. Many of our parents, they really brag about having a health center right there in their child's school. That way they don't have to miss days of work. That child doesn't have to miss days from school because there's a health center right inside of those schools, and we're broadening that out as well. Next up, we will hear from some of these amazing community health centers. We have 4 speakers here, 4 CEOs, and the first one will be Jenny Wren Denmark.
Good morning. My name is Jenny Wren Denmark, and I appreciate Madam Chair and the committee for inviting us here today to share some of what we do. As you see, we're going to all talk about different aspects of how we work with our communities. And what you'll learn from this is prevention is key. So we try to do a lot of prevention. Our aspect of some of our prevention was we started in chiropractic care. That is a different model. It's right inside of our medical facility, and it works together. The next mode for that for us is working into acupuncture as well to try to help prevent pain and to prevent use of any kind of narcotics for pain management. Some of the things you see pictures of is our hydro massage bed and our vibration plates, as well as our chiropractors doing manipulations. Our newest avenue is optometry. We waited a long time to get optometry. That's been a goal for years, particularly around our diabetic patients, because having access to an optometrist and having regular eye exams is critical for them. We started in a mobile unit, and we worked in a mobile unit for years, at least 2 years in a mobile unit, to try to get our building, our funding for our facility. We now have an in-house optometry clinic with 2 optometrists full-time, and we will then are going to refurbish our mobile unit and take it to our other communities as well. So that has been a mission that we've wanted for a long time, to help bring healthcare to our community. We did have one optometrist a few hours a week, literally maybe 10 hours a week in our community, and it was very difficult to get in with that person. So we really were able to bring a service into our area that was needed. The next thing that we are very proud of and waited, I would say, maybe close to 11 years, this has been in the plans, is student housing. In a small town, housing is a challenge. There's no apartment for rent. There's no place to all of a sudden put a student who's only going to be there 8 weeks or 6 weeks or 4 weeks. So for us to have access to an apartment, it's in our building. They don't have to have a car. They can walk. It's right there. We actually are located in Swainsboro in a shopping center. That we bought a shopping center, so it's on the back. So they're there, but they're tucked away, so that they can have their own private location. Because of this, they have a place to study. They have a place to be by themselves or work together. We have multiple disciplines in the apartments at the same time, so that encourages communication. We're able to bring in people even for short times. But the good thing is it's furnished, it's nice, it's pleasing, it's got, high-speed internet, because it's connected in with ours, and that's a big deal for some of our areas. This past year, we have trained, a health center trains a lot of people, and this past year, we just now started tracking, because we never really thought about it. And last year, we trained 31 students. And that's a lot, because most of them are about 6 weeks. So we did 186 weeks of training last year. That is only going to grow, because the more you train, the more you can recruit. And we almost always hire from our trained people. So whether it's a medical assistant, whether it's pharmacist, whatever we're training, that's our biggest method of hiring people. Because once they learn what we do, it just makes it part of their mission as well. One of the things that we are proud of is right now, this past year, we worked with 7 institutions to train their students. So we try to really target people that we think will actually come back to our areas. We don't necessarily care about training someone that is based on an online thing in Texas. We really want to focus. We know our positions are highly sought after for training. So the fact that we now get to be a little more selective, we're really trying to work on that to make sure that we're training who we might can recruit. And if we can't recruit them, maybe some of these other people can. So we work hard for that. One of our new things that it's not new now, but we were asked to join a nurse practitioner residency program. And we are in it with 2 other health centers like ours. It's starts in North Georgia and comes all the way down to our area. But that nurse practitioner program is training a licensed nurse practitioner with extra training. So when they come out of that 1 year, they've had all this other exposure and even more training. So for us, it's like a nurse practitioner with a 5 years experience, because they go out and they go and work with the wound care doctor, or they work with the cardiologist, and they go out to all these different places that we get them in, so that they come back to our area better trained and more self-assured to know who to call when they need some backup. Because for us, the transportation is a challenge, and we can make a referral, but if the patient doesn't go, we really need to be able to call the specialist. So the more we can work hand in hand, we've learned, the better it is. But having the apartment is a godsend to us, because we can just put people straight in there, and they have been well received to having them there. This is a picture of one of our physician assistants actually working with one of our students, so that they get hands-on training to be right beside them. Most of our people, when they are hired, they realize training is part of what we do. So it's in their job description. So they know that when they're coming. So they sign up. I will say, some of those tax incentives aren't hurting any, but it does make it where they want to teach, And most of ours realize the more they teach, the more they stay up, and the more fulfilled they are in their role. So teaching is a big part of what we do. The other big part of what we do is outreach. Outreach is education in all kinds of locations. One of our biggest parts is one of our offices is in Vidalia. And, you know, onions are hand planted and hand picked. So we go out to the fields and provide health care to the workers. That's really, really important to the farmers. They have to have the workers. And for them to have a healthy workforce, oftentimes we see them as they get off the buses for the first time in Vidalia. So we work generally, we don't even open those clinics mainly until about 6:30 or 7 o'clock at night, because during the day they're in the fields. They're not coming for health care. So you can see with some of these pictures how many people we see. We actually have full visits with providers. We take our physicians, nurse practitioners, and PAs, as well as sometimes pharmacists and other clinicians to go out and provide this care. This is a really big deal to our local hospitals, because providing the primary care first prevents the emergency care later. And it was such a big deal that one of our newer areas, it was in Baxley, a couple of years ago when we first were opening there, the hospital hosted a whole event for the farmers to come just to meet us so they could realize what we do and work with us to try to help reach their populations to prevent and also prevent the unnecessary ER visits. I will say those are all our mobile units, and that's how we do a lot of what we do. The other thing that we're really proud of is working with all of our community events. We work hand in hand with our schools. We have school clinics, and most recently we now have one at East Georgia College, and one here at Langston Chapel. They opened all this week. But we do a lot of hydration training and working with our athletes in our schools to learn about the importance of hydration and being a part. And it really encourages those students to be willing to talk to the providers and learn and understand. The better someone manages themselves, you can't do everything for them. But if they learn what it means and they learn what something feels like, they'll be more apt to talk about it. So there was the trip to the state championship, and down here sharing. The other things we do is work with our festivals. We take our mobile units, they are rolling billboards that encourage people to get in line because people want to go in and see them. So if we're not providing care on those days, which we often do, but if we don't, we let people tour the facilities so that they can see what it's like. We also go to local businesses, homeless shelters, particularly here, and battered women shelters, because we try to go where there's a captive group that needs access. So the other is any back-to-school events or senior citizen centers. That really helps us reach our people, because we have to reach outside of our doors. So I just wanted to share those with you, and thank you very much for your time.
Hello, everyone. Madam Chair and the committee members, thank you for letting us speak today. I'm Albert Grandy, the CEO of Curtis Cooper, and also the current president of GPCA. So I'm going to tell you a little bit about Curtis Cooper and some of the services we provide and some of the ones that other centers provide. Here you see, I just want to give a quick overview of the health centers. They have to have a board of directors, and over 51% have to be users. you can see from our board, there's certain individuals here that all of those in the community for collaborations, like our chair is the CFO of the school district. We have Attorney Braun, we have a banker, we have other individuals in, we have a couple of docs, retired docs, we have a ophthalmologist, we have a cardiologist. That's how we can get some of our specialist services done. And we have other people from the public housing. We have Helen Stone, who's a former county commissioner. So we have a diverse board so we can get things collaborative to see patients. Here we have, we've been in business 50 years, be 51 years for our system of care. We had over 30,000 patients, 95,000 visits. We have 260 staff. You can see 42 medical providers. We one of the few to have dental staff. We have behavioral health. We have patients in a medical home. We speak about quality, and we've been doing integrated behavioral health for over 10 years. This is just some of our sites and some of the size, but I'll go over that a little later. And also we do work at the detention center in Chatham County. We take care of the HIV patients and women's health to pregnant individuals as well. These are some of our services around adult medicine. One of the ones to speak about is Prevent Blindness Georgia. We actually provide free glasses for the individuals. Ophthalmologists actually come and do some of the exams free so the individuals can get the vision care that they need. From that standpoint, we do some specialty research around HIV, and I'll speak more about OB in a minute. Around the dental services, we have radiology. One of the few health centers got a 3D mammogram, so we do ultrasound, so we have the radiology on site that's affordable. With pharmacy, we have a patient assistance program. We have PharmDs. Therefore, the individuals that need counseling on the medication, they can also be provided. We have 3 PharmDs and behavior health. And we have mobile health, and the e-specialist is something that we just started, that we actually have e-specialists through our telehealth. Therefore, when the individual needs to see a specialist, I know if you even go to try to get a specialist today, it's going to take you 6 weeks, maybe 8 weeks, that we can have them tune in through the telehealth through our system, for they can get some consultations while they have a visit as well. This is where we, really the counties that we cover, from Effingham, Chatham County down to Bryan County. We do the northern side of Bryan County, more at Pembroke, because the southern side is cut by Fort Stewart, so the bottom part of Richmond Hill, and it gets towards more Stephanie and all the way over to where Jenny Wren started. And so we obviously in Savannah we have a lot of tourists, and most of it industrialized in that area. So I'll go back to our actual services that we provide. Also, we have interpretive services online, things that we do, obviously podiatry and dentistry. We have, all the new technology. We had digital panorex, all the digital bites. We do affordable dentures. We do also crown and bridges. So we provide a lot of services. We also in the schools, we're in 34 schools. I know RB gonna speak more about it. We have 34 schools, got 5 mobile vans. So we've been in the school district as well. Currently, we get ready to go into Effingham School District. We started doing behavior health with Effingham Hospital with Speaker Burns. I know Representative Hickman was there as well during the time, and we're expanding that to prenatal services there, because no prenatal services really from Scriven all the way to Savannah. So we have another big collaboration with St. Joe Candler, and I'm gonna speak about that in a minute once I show you the site from there. And these are just some of our locations. We also at Savannah State, we provide family planning services there. I just spoke about Effingham Hospital. What we call our Women's Center, I speak about that. That's actually at St. Joe Candler, the Candler Professional Building. We had 8,000 square feet, even though we provided at other sites, because we got 14 delivery sites around the 3 counties. And this just a picture of our main site on East Broad, and that's in some of the pictures inside of one of our mobile vans. I think that's the dental van at the bottom left. The one picture in the middle, that was Pembroke before the tornado tore it down. Then we had another one built, and then recently they had us trying to move to another site, and that's just another picture of our main site. And then in terms of the hours, we open at 7 to 6, 7 to 7 certain days now, and on Saturdays we actually have sick call in the morning, so at 7, so people can walk in, whether it's school, other people to work as well. And this is just the Women's Center, and I just speak more about our women's health and our collaboration with St. Joe Candler, with Mr. Hinchy and his staff, is that we have 3 OBs. Thank you, Chairman Taylor. Today we got 4 OBs. The one that do high risk. You know, high risk could be most of the individuals may come in the second trimester, or they have chronic conditions. So therefore, we deliver babies. We also have a collaboration with St. Joe Candler, provide prenatal services, and they deliver because they got hospitalists or laborers just for the babies. And that started from Scriven all the way to Savannah, and from Wayne County all the way back up to Savannah, because unfortunately Georgia has one of the highest infant mortality rates. And there's just another one of our locations. That's in the public housing. That's at Savannah State. This at Gateway. We have a collaboration with Gateway for behavior health, and they have a psychiatric residency program as well. And this one of our dental practices we integrated with us. And then this is that we have 2 on-site school bases, and we go to 34 other schools. We have 5 mobile vans. And this was the temporary site, Pembroke. Since then, we had to move, so we have to get another site in Pembroke because they're doing some development there. And that's where it was the initial site. And this is another one of our sites we just have for pediatrics behavior health. And this is another site that we have in Savannah. And this is a site we have in Rankin and Effingham. And this was with the hospital that we integrated behavior health, and we get ready to put prenatal services there as well. And this is just one of the vans, and I want to thank everyone for this time, and always leave everyone, I always say last night my 333, but I'm going to go back to my 222. You can spend $250 for a primary care visit, or you can spend $2,500 average for an ER visit. And if you don't spend the $250 for the primary care visit, you're going to spend $25,000 for an inpatient visit. Then you can add all the zeros you want at the end, but it never replace the death of a loved one. So we need to do primary care first. Thank you.
Good morning, Madam Chair and the rest of the committee. My name is Stephanie Jones-Heath, and I'm the CEO of Diversity Health Center, and we're in Liberty, Long, and Wayne County. Just a little bit about myself. I'm originally from Columbus, Mississippi, from a family of 6 who were farmers growing up. My father had over 100 acres of farmland, and we grew up working in the fields, and I said 2 things I would never do. One is I would never marry a farmer, and then I wanted to leave home as soon as possible. And I did that, but then I ended up in Georgia after joining the military and marrying my husband, who's retired military, and I ended up in Georgia working at a federally qualified health center. And the first thing I wanted to do was to start a community garden. So we're one of 2 FQHCs in the state of Georgia that has a community garden, which is what I'm going to talk about. So thanks, Dad, for instilling in me about healthy eating and healthy cooking, which goes right in line with a federally qualified health center and some of the things that we're trying to do, which is around food is medicine. And I grew up where food was loved, because if you grew up in a household in the South, when you ate and you cooked and you all gathered together, that was a form of love when you cooked. So quite naturally, when I took over the federally qualified health center here, and we had a big piece of property, and I said, I want to build a community garden. So back in 2019, I constructed our first community garden, got together with people in the community, and we built the community garden with a total of 12 beds. And so with that process, it kind of expanded into where we are today, which is food is medicine. And so we utilize our community garden along with all of the things that the previous speakers talked about through traditional health care, but we innovated and added in the food aspect. So we do food demonstrations from food that came out of the garden, because you take for granted that most people know how to cook fresh food. But today, a lot of people don't know how to prepare fresh food. So it's from food, from garden to table is what we call it. And we utilize the garden now. We also utilize it for therapy. So we have behavioral health therapy out in the garden. We do classes in the garden. We work with community partners from senior homes that come out and work in the garden. So it gives people an opportunity to learn about healthy eating. And so we've expanded that into our preventative health care that we provide in the center. So we take some of our patients that have a high A1C rate as far as diabetes is concerned, and we take them out in the garden and we talk to them about how to just change some of the ways you prepare food and how you season food. And so we utilize the garden as a mean of communicating the change in the way you eat, because for most families, you learn how to cook from your parents and from your friends and your family. So we try to say, we don't want to take away what you eat, it's just how you prepare it and how much you eat. And so what we've been able to do is we've been able to take patients that have come into the clinic that had an A1C of 17, 16, and lowered their A1C below 5, and they're no longer on medication. So we realized that the garden was working. We realized that food is a form of medicine if you utilize it the right way. So we've expanded that program, and we call them our champions. So we have patients we had one patient that was a truck driver, but was no longer could be a truck driver because they couldn't pass their physical because their A1C was above the rate for being able to drive. And so we were able to change their food habits and the way they prepared their food, and his A1C went back down, and he was able to pass his physical, and he was able to go back to work. So those are the stories that we like to share. So we utilize him as one of our champions, and he comes out to our group classes and he talks to our patients about what he did. And it was simple changes, because in the South, we all love sweet tea. And so, you say tea without sugar, people are looking at it like you must be from up north, right? Because we have to have sugar in our tea. So we talked about little changes, like instead of adding a whole cup of sugar to that tea, let's cut it down to a half a cup of sugar to that tea. Then it's like, let's add more water to the tea instead of adding the water that you used to add to the tea. So we taught people different ways to still enjoy that sweet tea, but let's cut back on some of the sugar. So now we're up to 12 champions. We're up to 12 patients who had an A1C above 15 that are now no longer on any medication. And they have been taking medication for years, and they're no longer taking medication. We have one patient that was on disability because they no longer could work, that's now back to working. So those are the preventative measures that we want to see and to continue to improve upon with what we do. And as an FQHC, we have those opportunities to work outside of what we typically do with traditional medicine. And we're able to spend that time with our patients to talk about different ways that we can address and approach how you eat, how you spend your time. And we believe in not just treating the physical body, but the spiritual body and the mental body of a patient. And that's what makes you whole. And the second thing I want to talk about is veterans, because I'm a veteran. And my husband is a disabled vet, and I'm a disabled vet myself. I served in the United States Army, and while I was in a plane crash, but we're survived because I'm here right now. But part of what my passion is also is making sure we're taking care of our veterans that are in our community. And Fort Stewart is the base that's in my community. And so we have a partnership with the base because for veterans, once you turn 65, you basically graduate out of the VA system. And so those patients have to find another place in order to seek their care because they're now on Medicare and different forms of coverage at that age. And so through that partnership with the VA, those patients are referred to Diversity Health Center for their continued care. And the great thing about us is we see patients regardless of your ability to pay. So for a lot of those spouses of those veterans that have passed on, then they're looking for a medical home because if you know anything about the military has a security blanket when it comes around health care, and we have access to care. So if that access is taken away, then you're looking like, where do I go? And most of the time you might be in a community that you didn't grow up and know everybody in that community. So having that partnership to transition those patients out of the military system where you have all of that access to care to the traditional system within the community, having something like a federally qualified health center to transition those patients to, where they know that they have access to not just the health care, but to behavioral health. And in most of our centers, we have all of that in one location. So you don't have to go from 4 or 5 different buildings in order to get your health care. And so from the standpoint of knowing and not understanding at a young age what God has for you to go, those two things that I never wanted to do, I ended up being the passion of my life and the purpose for why I'm here. So thank you for the opportunity. I have the full slide presentation of the food for medicine that Becky will be giving out at the end of this, and hopefully you'll read through it and learn more about food as medicine. So thank you very much.
Madam Chair, members of the committee, thank you so much for allowing us to speak to y'all and share our stories on what we do all across the state here. My name is R.B. Tucker. I'm the CEO of South Central Primary Care, and as the name implies, we have offices in South Central Georgia, starting in Atkinson, Ben Hill, Berrien, Coffee, Lowndes, and Irwin counties. My purpose here is to speak on behavioral health and school-based health centers. I'll start off with the behavioral health, and let's talk about the need. Community health centers collect a lot of data on our patients, so we can tell what kind of conditions they have. This data is combined, it's sent to Washington, and then it's combined, and then you can drill down on it at a state level and see really the population that was seen by health centers, what their problems was, that kind of thing. If you look at behavioral health diagnoses in our area, we had tobacco disorder at 8%, depression 8%, anxiety 9%, attention deficit 8%. But if you look at the state level, looking at 6% on tobacco abuse, 8% depression, 9% anxiety, 3% attention deficit. And the state sample is right at 750,000 patients. At South Central, ours is a little under 17,000. But if you see, even at 17,000, it's almost the same at the state level. Another measure that is not as considered, let's see, and this is my as background in cost accounting, I always look for problems. And one of the things that causes a lot of deal, and I believe it's related to behavior, is obesity. At South Central, 53% of our patients are diagnosed as obese. At Georgia, it's 48%. What runs with obesity? Hypertension. And South Central is 20%, at Georgia is 24%. And its partner is diabetes, which is at 10% at South Central, and Georgia is 12%. Many of these health centers here, we have integrated behavioral health. We currently employ a psychiatric nurse practitioner, 2 licensed clinical social workers, and 1 licensed professional counselor. They are housed and work inside the same offices as our medical staff. In theory, this allows for warm handoffs and also hopefully breaks some of the stigma associated with behavioral health. We have worked with community service boards in our area. It's Unison and Legacy on a RCORP program. And RCORP is an acronym for Rural Communities Opioid Response Program. The aim of this program is to prevent and treat opioid use disorder for people in rural areas. One of the most successful parts of our behavioral health is providing counseling at school-based health centers. We provide counseling in different schools, 2 in Ben Hill, 2 in Irwin, and 1 in Coffee. 2 of these locations, which is the Irwin High School and the Coffee High School, is a direct result of the school system asking for help in counseling. One thing that they say that we deliver is consistency. And consistency is consistency in scheduling. When we schedule an appointment, we have somebody there to see the patient, and consistency in the provider, and that the patient will see the same provider next week as he saw this week and the next week. So that seems to help. This leads me to my next topic, school-based health centers. We have 3 sites that provide primary health care and behavioral health care. One of these is in Irwin Elementary School and is a result of startup funds from the state of Georgia. So thank you guys for funding that startup there. We have 2 in Ben Hill County. One is a middle school and a result of startup funds from Emory University, and another one is at the high school and a result of Governor Kemp's School-Based Health Center initiative. We opened last year in the high school at a temporary part of the school, and we're opening a permanent site at the end of this month. Last year, we saw a little over 1,500 patients in the schools. 35% of these were teachers, staff members, bus drivers, adults. I will say if you've seen one school-based center, you've seen one school-based health center. Some are based on mobile units, some have standalone buildings on the campus, and some are like us, we're located inside the school. All school-based health centers are operated with the school board and administration, collaboration with those. South Central, ours is located inside the schools. We like this model because it allows easy, efficient access for the students. Our Ben Hill County School has direct access to both inside and outside. And our new one that will be opened up at the high school will also be the same way. You can come directly into the center from outside and inside. The services that we deliver at school-based health centers: treatment for acute illnesses, lab tests with strep, flu, urinalysis, COVID, health checks, immunizations, chronic condition management such as asthma, diabetes, etc., sports physicals, counseling and mental health, and referrals to specialists as needed. We work in partnership with the school nurse. The school nurse is the first line of care. All of our patients go, except maybe the adults now, go through the school nurse before they come to our clinics. No child is seen without written permission from the parent or legal guardian. Parents may participate in the child's appointments through a phone, through a computer, or in person. totally up to the parent how they would like the kid to be seen. I'd like to dispel some untruths that's going around on the social media and kind of likes to get passed around. And what's passed around is that we will see kids without the adult. And as I just said, we do not see anybody without an adult or a guardian. In fact, that's part of Georgia law. It's the vague language in the sign-up sheets. Ours is basically the same documents and forms that you would fill out if you go to our pediatric office. There's nothing vague about it. Our services go unchecked. All of our school-based health centers are operated under the same guidelines as any medical office in the state and nation, for that matter. And then the last one I like is beneficiaries of school-based health centers are big pharma, mental health contractors, and corporate health care. That is far from the case. We're all nonprofits, and what we want to do is cover our cost so that our program can be sustainable. That's what the startup funds was, just to start us. After that, it's on us. We have to generate enough revenue to continue on. I'm going to end with a little positive note about health centers, or school-based health centers. Students spend more time in the classroom. That's a benefit for school-based health center. Those 1,500 individuals that I saw, that I told you about earlier, the majority of them were able to go back to their classroom to learn or to go back to teach. Very few had to go home. If they had a contagious fever or something, yes, they went home. But outside of that, they went back. That's a big advantage. Second, students tend to do better academically. Of course, if you're healthier, you're going to learn more. Students are sick less because health care is readily available. And parents and guardians do not have to miss work for the child to receive health care. Teens are more apt to seek help from a school-based health center than a private doctor's office, just because access. There's one other thing I would like to say, and that there is a population in the schools that do not have a primary care provider. And the reasons this can be vast. But one of the major ones that we see is their parents work, and they work at the same time that the school's in session. Either they're working or they're sleeping because their job is at night. Access to the school allows the kid to have a primary care provider at the school. It was estimated by one of our school officials that there was 40% of the students that did not have a PCP, a primary care provider. So you know where they ended up is in the ER. That's where they got their primary care. So anyway, I think school-based health centers is a great idea. And appreciate this. Thank y'all.
Thank you so, oh, we got, yes.
No, I just want to say, Madam Chair, it's just a variety of what community health centers do or FQHCs do. And if you would like, the panel would entertain whatever questions you have.
Absolutely, absolutely. Would like to open it up for questions and lead off with this. How long is the average wait time for new patient appointments? I guess just maybe across.
I think for us, it depends on the site. I mean, for a new patient, we always being patient-centered medical home, we always have same-day sick appointments available. But for a new patient, in some sites, if you will see any provider, it's quick. If you want to see a specific provider, it might be longer. So anywhere from same day to 2 or 3 days, or if it's the specific person and you want to be on that panel and that panel is very full, you may be 2 weeks out.
In our center, within 3 days, we can get a new patient on the schedule.
We also have a walk-in, so you can see the same day from the standpoint, depends. You have acute issue, and we get you in the system.
we have walk-ins. There we go. Can you hear me now? Now, we have walk-ins just as soon as they can get in. The paperwork filling out if they're a new patient might take a little longer, but like in the school-based health center, it's walk-in for any kind of thing. And really, from a competition standpoint in our area, the urgent cares are right there, so if you don't take walk-ins, they're getting them. So, you know, that's what we're here for when you're sick. So.
Yeah, I was just going to add that the vast majority of our health centers are patient-centered medical home. They're certified, and they have to have same-day appointment slots available as part of that certification.
Chairwoman Taylor.
Thank you, Madam Chair. I'm very familiar with the FQHCs and the great services that you provide, but I think one of the things this committee will want to look at, what is the process to start one? What is the cost associated with it? If we can duplicate what you're doing in some of our rural communities, but we need to know what to expect in cost and time-wise, whether it be for a school-based or just a brand-new clinic. Anybody want to take that one?
Well, it depends upon the size, scope. You could put a family medicine doc, depending upon you have a site, whether you own it or not. You might have a lease. So depending on how many exam rooms, if you're going to do any other ancillaries. So it could range from $250,000 to start, depending upon the salary and having nursing, like $300,000-400,000. That's be your cost to $1 million, depending upon what you're going to put in that site, just to start for the complement of services. But I would say that the minimum, it'll be at least $400,000 because you just have the cost of a doc and benefits and the nursing and the other staff. That's not including any facility costs from that standpoint or equipment.
And if I could follow up, to be sustainable, this works so well in your communities, but again, we have some counties where they have less than 2,000 lives in it. So how can you, I don't know that you can sustain a full-fledged clinic. Am I reading that right?
Well, I have some very small clinics in some very small towns. And you're right, you can't do everything all the time, but you can reach the population. In those counties, we generally operate with a nurse practitioner or a PA. It is not going to balance if you put a physician in there. It's just you're right, it's not. That same situation happens with a school that's very small. There is a diminishing return there depending on your volumes. So what we have done is many things. One is we use mobile units. One, we use shorter hours. We share staff amongst sites. We rotate a physician through there. We do different things, but you're right, there is a difference.
Thank you.
Also, we add telehealth when it's possible. Obviously, broadband is a little bit not available everywhere, but on a phone, you can use the phone and you can, from our electronic medical record, they could do telehealth visits with the provider for screening purposes from that standpoint to some form that provide more access.
Representative Hagan.
Okay, thank you. Thank you all for being here today. It's been very interesting to hear about the diverse programs that you offer. And but I've got two questions specifically for Mr. Tucker. Part of the district I represent is in Ben Hill County, and I've been able to visit the high school location, your SBHC there, and been able to hear about how impactful it has been there in that community. So I had two things I was wondering about. One, do they have summer access to that particular location, or is it only during the school year?
With the middle school, we operate during the school year. So if there's no staff there, we do not operate. But with the high school, I understand that it operates 12 months out of the year. And
Okay.
if that's the case, we will be there.
Mm-hmm. So,
If teachers are there, we're there.
okay, yeah, I was curious about that. And then I was also, I felt like I remember hearing something about this when I toured it, but I can't remember. So I just want to ask you, do you see family members of students and staff?
Yes.
You do. So
Yes.
it's a whole, if they're a student at the school or staff member at the school, then their whole family has access?
Yes.
Okay, that's
That
interesting.
helps with the outdoor, being able to come into the clinic from the outside without having to walk all the way through the school. So that helps in that.
Okay, great. And I imagine, I think keeping kids and staff at school, learning and working, and then also keeping their parents at work. We've got so many workforce issues and shortages. I think anything we could do to keep people at school and at work instead of having to take that time and go to some other doctor's office is a huge help. But thank you all again for being here to present to us today. It's been very valuable information.
So ending with this question, again, this is for all of you. What are your top priorities for this next year?
Our priority is more case management, more patient education, teaching them to better help themselves with the tools that we can help provide, a blood pressure cuff, just like the basics that some need. I think that's our biggest goal this year because we can see an outcome change when this happens.
And our top priority is to expand around prenatal care for women because of lack of it and access and the limited amount of OB services, especially in that area. You have retiring OBs. You can see in different areas, a lot of hospitals don't provide OB. So that's the first one. We work with St. Joe Candler just to have access. But people come in and say in the second trimester, they're already high risk, some third, then you're really getting into some real issues around reproductive care. And second is around behavior health, because before we went to Effingham, it wasn't any behavior health for most individuals in Effingham County. So we're expanding that, and we have integrated care around there from behavior health, medicine, and dental, because all of them related. So that's what we focus on more in the integrated, but really highlight just access to behavior health services.
And our focus is to expand on some of our best practices because we've been doing a lot of different ways that we've been presenting care, which again, like I said, through the community garden. We also have a radio show where we utilize those services to highlight some of our best practices and being able to expand on that in different ways and working with additional community partners. We have housing developments that we're working with to expand on our community garden, where they will be providing community gardens within those housing developments, and as a community health center going into those neighborhoods to teach them about healthy eating and expanding, because we know it works. So we figured out a formula that works, so around that we want to expand on that over the next few years. And then the big words that we've been using this year is accountability. is having accountability measures in place to be able to show the work that we're doing, because as you know, everything is around accountability right now. So if you can show where a patient has gone from 17 to less than 5 with their A1C, and being able to tell those stories. So we're going to focus on really being able to tell the stories of community health centers and the work that we're doing.
Our emphasis to start with is we need 2 pediatricians and a family practice dog.
Yes.
We've had some retirements, and we've been searching, and it's very difficult to recruit in rural Georgia. And so thankful we got residency programs starting in rural Georgia so they can see, we do have running water and TV and all the benefits of living in town. We would like to put some better emphasis on behavioral health and try to reach more people with that. We've just, with our psychiatric nurse practitioner, she's our first one of that discipline, and hopefully we can expand on that because they're more easily recruited than a psychiatrist, so maybe we can spread those out a little more. But there's a big need for behavioral health, and so we would really like to be more successful at that than where we are right now.
And on the PCA level, we're looking at, because you've heard some of the needs here, is to increase our workforce, encouraging more of our health centers to become teaching health centers, have residency programs, to see more internships coming through our health centers. We're reaching out to residency programs along with med students, and as I heard Dr. Gerges say, even going to the high school level and teaching high school students about medicine and the different jobs and careers that they can have in medicine right here in Georgia. And so we're trying to expand that workforce to get folks to stay here in Georgia to practice.
Thank you all so much. I appreciate it, and you are definitely having an impact on your communities. Oh, I'm sorry, excuse me.
One quick question. If you want to expand to another community or add an additional service, is it government or state regulation that you have to go through to get approval for that? Or since y'all are doing what you do, you can expand and just go through the normal building out or whatever for local communities?
We can expand, but we have to be careful that we can expand and not pull away from something we already are doing. That's really important. We do receive some federal money, and that has to stay in the areas of what it was funded. However, we do collect some money, and that money we can invest. And so often we invest in another service, we can invest in another community, and we can apply for another grant if there's a grant cycle going on at the time. So that's how we move forward.
And it also is a requirement if you want to be recognized by the federal government is a change of scope. So you have to submit that, and then there's certain benefits around that. You'd be eligible for 340B, loan repayment from that standpoint, and malpractice insurance from FTCA. So government really covers the malpractice. But it's some, those benefits from that, having that site is designated as a federally qualified health center, what we call community health center.
Thank you.
Chairman.
Yes, thank you. Just to follow up on that a little bit, I want to remind the members of the committee, the House and the legislature for a number of years now has included in the budget startup money to start up new sites for the federally qualified health centers. And the House has been a leader in that for a number of years, and this year in the budget, I think there was startup money for like $250,000 for each. And usually the association will have a list of those who would like to start new facilities or new services. And so this is seed money that the legislature puts in place, and it's sort of a one and done. It's usually the $250,000, and then that's the end of the obligation from the state. So in my mind, it's been a great return on our investment. We invest $250,000 and you start up a new service. And in the beginning, it was all primary care. And then we began to look, as was pointed out, that was part of the project, but also behavioral health was another large part that wasn't being addressed. And now your school-based clinics are another area there that's filling a need too. So I think the legislature can be very proud of the fact that you've been a leader for a number of years to help start these new clinics and these new services. And it's a great return on the state's investment in my mind.
Thank you all very much.
Thank you.
We are going to go ahead with the Georgia Trauma Commission, and we're just going to push lunch back 30 minutes if everybody's good.
Good morning. So my name's Courtney Twilliger, and I live about 40 miles due west of here, down to Swainsboro, Georgia, Emanuel County. I've lived there practically all my life. I moved there when I was 5. My mother's family's been there for ages and ages and ages. My dad's family was from upstate New York, hence the name Twilliger and the little bit of a Yankee attitude that I have on occasions. So I want to talk to you a little bit about EMS. And how it impacts rural Georgia and the challenges that we have in rural Georgia, in particular with primary care events in rural Georgia. So EMS is not a normal medical group. If you look at EMS, it encompasses healthcare, it encompasses public safety, and depending on who you ask, if you ask a fire-based EMS, they're public safety. If you ask a hospital-based EMS like ours, you're going to probably get, well, we're public health. And the bottom line is they do both. Even our hospital-based service, we respond to automobile accidents, we respond to industrial accidents, and indeed the fire-based services respond to everything too. So it is a merger of all of those, and it is a fairly unique industry. So I'm going to give you a little bit of history. So essentially, well, let me stop back. In 1965, a year before this was, my brother John, my older brother, was in a car crash, and he was driving I forget what it was, a little Volkswagen Beetle, and he flipped it end over end, threw him out, found a pine tree, and we are a hard-headed family. He wasn't that hard-headed. So my dad was right behind him and found him and had to leave him there to go find the phone. There were no cell phones at that point. There was no 911, so he went and called the funeral director. That was the transportation mechanism in that era. Fortunately, a guy named Josh Honeycutt had taken some training. Wasn't required, but he did. So my brother ended up at it's Emanuel County Hospital at that time. Did an x-ray, and the x-ray quality was not there at that time. Spent the night in our hospital till the next morning he started suffering paralysis. And he ended up spending 6 weeks at the old University Hospital. And they told us when he first got there, he said, well, he's only got a 50-50 chance of surviving, and he'll never walk again. And my brother walked again, and he lived a full life. He has children, grandchildren, and now he's 77 now, and he's back in a wheelchair, but he's had a good life. Today, if that same accident happened with the EMS system we have, I feel comfortable that he would have never suffered paralysis. So anyway, 1966, accidental death and disability. We call it death in a ditch. That's just our terminology. But it was the start of EMS as we know it today. Notice it was trauma-based. There was no, when they were developing this EMS system, there was no thought of cardiac, there's no thought of stroke, there's no thought of OB. All of those things just were not of interest to anybody, okay? Well, I take that back. They were certainly of interest to some folks, but they were not of such that they wanted to make a huge change. It was a trauma thing. Now, on this slide, I want to point out that right there, because I'll come back to that particular point several times. So if you look at the one on the left, although that tag says New Jersey, I rode in one that looked just exactly like that. So that was my first ambulance. We also had a 1969 Econoline van that that had a 302 engine in it, and both of them would go faster than we needed to go, and we were young and stupid. I want to point out that that is a current ambulance in Emmanuel County, and what I want you to think about there is everybody in here recognizes that as an ambulance. What you don't have a clue about is the capability of that ambulance. You don't know the people in it. You don't know their level of training. You don't know the people in it as to what capabilities they have as far as the equipment and the training. You, as a citizen of Georgia, you have an idea and an expectation of some certain things, but sometimes those are not correct. So on the left, that was the tools I used when I started in 1977, and that's pretty much what we had, okay? Over on the, over here, that yellow thing is a stretcher, and attached to that stretcher is a device that actually comes out of the ambulance, gets the stretcher, picks it up, carries it back in. For that device right there, I could buy 3 hospital beds. That's how much those things cost. The cardiac monitor there is the LifePak 15, costs about $28,000. It'll do waveform capnography. It'll do end-tidal CO2. It will do. I'm trying to think of pulse oximetry, non-invasive blood pressure, and 12 DKGs, and we'll transmit all of that to a receiving facility if that's something that you want to do. Oh, the other point, that's a Zoll ventilator. It's a hospital quality ventilator, and back during COVID, we have 5 of them. 3 of them were in our ICU, taking care of the COVID patients. So that's a Lucas device. It does CPR, automatic device. You plug it up, battery operated. So now this over here is a McGrath laryngoscope. So this right here is a video screen. So now instead of using a handheld device, well, they're all handheld devices, but instead of using a standard laryngoscope blade, we can use that, and the medic can actually see the end of the endotracheal tube go through the epiglottis, and that is huge, because if you put it in the wrong place and you don't know it, they will die. That's just a simple thing. So then when I started 100 years ago almost, we ran 50 to 55 calls a month. We hit 55 calls, we thought we were killing it. We thought we were just busy. Same community, almost the same population. Now they run 400 to 428 calls a month. Population hasn't changed much. The volume has. The one thing I want you to pick up here, 2 to 4 transports per month versus 100. When I started, if you had an issue in Emmanuel County, you came to Emmanuel County Hospital. If you had a heart attack, that's where you came. If you had a stroke, that's where you came. If you had trauma, that's where you came. I used to get calls in the middle of the night to come to the hospital and donate blood because they were going to do surgery on a trauma victim. And my smart comment about that is everybody went home. They either went to their home or a nursing home or a funeral home, but they left Emmanuel Medical Center that way. And those 2 to 4 transports a month were generally to Talmadge Hospital. Some of you remember that term. And that was because they were indigent and they were sending them up there so that the state would pay for it. So a little bit more history, the agenda for the future, 1996 and 250. And then the one I really like, this right here, 207, regionalization of care. It's the first time, it's a big book, first time that I remember that they put EMS as part of the healthcare system, because that book actually talked about pre-hospital and in-hospital care and as both on emergency medicine. So it's, the other thing that I want you to remember is this. We have made some great improvements in equipment, training, but the bottom line is the system is still designed the same way. And here's proof of it. This is a current visual from the Veterans Administration. So their idea is that you have a wreck, the ambulance comes, takes you to the hospital. Pretty simplistic. And if you live in a big city with a trauma center in your hospital, in your community, that might be exactly the same way you do it. But if you live in rural Georgia and you take them to the local hospital and they got critical trauma, and in some communities in our state, the local EMS will take them to their local hospital who has no capability to handle that trauma and leave them there. And they die because they've got to get to a level 1 or 2 center if they're critically injured. And if they don't, the bottom line is that rural hospitals don't have the capability to taking care of that critical trauma. Transportation is a huge issue in what we do. So systems of care, and I want you to think about this. These are the 3 that we look at: trauma, stroke, and ST segment elevation MI. All right, that's a specific type of heart attack that a cath lab can do a lot with. If you get them to a cath lab timely, I'll tell you my story. I told it 100 times. The guy had the same color hair that I do. All right, he's a couple years older than me. He was a veteran. He came back to Swainsboro, worked at our hospital, and then retired again, and he did it like all men do. His wife called one day about 5 o'clock in the afternoon and said, he's got chest pain, come see about him. So we did. We did what I refer to as a woo-woo thing. Woo, 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 woo. We go down the road that way, get to his home, and he says, I want to go to Manual Medical Center. I got friends up there, work there. They said, no. They did a 12-lead EKG. My folks knew how to read that, to know that there was a STEMI, a certain type of heart attack. Said, you need to go to Dublin. No, I don't want to go to Dublin. You need to go to Dublin. After a little while, they convinced him. And then Adrian, the cooperative patient that my friend was, he died. I mean, we ask them not to do that, but sometimes they just do. So they did what we do. They pulled out a defibrillator, defibrillated him, got him back, took him on to Dublin. We'd called ahead. They knew what was coming in, went straight to the cath lab. Bottom line is, 2 days later, they wheeled him to the front door of the hospital. He stood up, walked out, got in his car, and went home. That was 8 years ago, okay? I saw him at the local grocery store several weeks ago bagging his own groceries. So that's what you can do if the EMS in your community knows what they're doing, has the proper training. And here's a couple of maps, and you can see those, essentially the different specialty care centers that the state identifies. But if you look at all of them, you will notice certain areas of the state that those things are not very convenient to. Whoops. Years ago, I got to be the quality insurance coach at our hospital. They sent me off to Nashville, Tennessee for a lot of training, and I learned about this guy, W. Edward Demings. And if you remember those days, there's always these buzzwords, but that was the CQI or the PI. That was kind of the start of it. W. Edward Demings was a statistician, and if you think about and you've heard about the Japanese management system, this American designed it, okay? So his idea was every system is perfectly designed to get the results that it does. EMS gets the results that it was designed. Remember, I'm telling you, it was designed in 1966. It has not been redesigned. Hospitals and healthcare have been redesigned. They've got specialty centers. They've got people in the hospitals that are tremendously better trained than they were when I started this profession. It is remarkable. Oops, I'm going. And so the objective of regionalization is simply to improve it. The bottom line is if you do trauma surgery once every 6 months, you're not going to be very good at it. I don't care who you are. If you do it 3 times a day, guess what? You're going to get better at it. And then the trauma centers, I'm on the trauma commission. One of the things we spend next Thursday, they will have a whole day session looking at data from patients in the hospitals and the level 1 and 2 centers to see If one hospital does it better than the other, can we take that information and take it to the other hospitals and learn from it and improve what we're doing? And that came out of that book I was talking about a while ago, the National Academy's Emergency Medical Services at the Crossroads. Again, that was, to me, the father of regionalization. So why does it matter? Gosh, if you're a physician at our hospital, you've got a decision to make if an ambulance brings that patient in. What do you do with that patient? Do you put them in our hospital, or do you transfer them? It makes a difference, because if you put them in the hospital as soon as they're admitted, EMTALA law doesn't take effect. And some physicians have one heck of a time when they get a patient in, they're taking care of them, need to get them transferred to a higher level. Well, the higher level is not required by law to take them. But if they're in the emergency department, still in an emergency situation, the federal law says if you offer one of these specialty cares, you got to take them. Do not take them, cost you $50,000 per occurrence. Okay, that's the EMTALA law. And they can charge the physician $50,000 too. So are physicians concerned about EMTALA? Yes, they are. So it makes a difference, okay? And then the loss of revenue, and my physician is an internal medicine doc. And when we started talking about STEMIs and direct transfer to cath lab, she was all for it. She said, but if they don't have a STEMI, bring them to us, we can take care of them. So if you're a physician, you transfer them to another facility, oftentimes you lose that patient. Now instead of coming back to you, they're going to that specialty doc. For me, I got a cardiologist in Valdosta. How smart is that? Okay, 3 hours away, but Randy Brown was my doc down there, and so I ended up down there. So continuity patient care, and if you go on if you're transferred to another hospital, the local physician is your primary care physician has one heck of a hard time getting all the medical records back to try to figure out how to take care of you. No physician-owned practices in Emmanuel County. That's completely different than when I started. Every physician had their own practice. It is a different world. Why does it matter? This is a case that came out of South Georgia, and there was another case. This was a teenager, a high school kid, who got shot, and he died. Waiting on an ambulance for 30 minutes. The other case that I printed it off and then lost my paper, the other one was a 16-year-old girl who was involved in an automobile accident, same school, same rural community. About a month and a half afterwards, she died also. She waited 45 minutes for an ambulance. Can you imagine being that parent? Can you imagine being that family? It matters. It matters. So this one, I want you to look at this. This is ground ambulance, 22-23. Average response time in 22 was 12.5 minutes. Average in 23, 19.4. Is that a difference? The theoretical goal is 8 minutes. There is no, and people will tell you that's a national standard. There really is no national standard. Nothing written down like that, other than the fact that that's pretty bad. So this is the top ranked priorities on the Trauma Commission. We got a group from University of Georgia to do a survey looking at what we do. And this was a survey done with level 3 and 4 trauma centers. This is small rural trauma centers, okay? All of these facilities that they surveyed are designated as a level 3 or 4 trauma center. It doesn't encompass all of the rural communities, all of the rural hospitals, just those. And what I want you to get out of this is improving rural transport. It was ranked number 1 by 43% of those responding hospitals. It is a huge problem for them to get patients out via ambulance. Transport availability, 69% of the barriers that they deal with. Now I want you to think about this. These are trauma people that are saying this. Stroke people will say the same thing. Cardiac people will say the same thing. Challenges, air EMS availability, 79%. Financial priorities, transportation, 38%. Notice the number ranked number one was ranked number one by a greater percentage than any other. Transfer delays are operational, not clinical. Some of that is based on availability and resources. Some of it is based on attitude. And I've got a slide here. I hope to point that out. But so I put this in because I know later in the day y'all got a thing on telehealth. Okay, the Trauma Commission funds AVLS, automatic vehicle locator systems, and we offer it to every county in the state of Georgia. So if the county is in red, it doesn't mean they don't have them. Madam Chairman, Gwinnett County has it. We just don't pay for it. Gwinnett County pays for it. We're tickled with that. So all of these counties, I think there may be 2 or 3 counties in Georgia that don't have that. Now, I say AVLS, y'all need to think Wi-Fi capability. So those ambulances have Wi-Fi capability. I could look at my phone and tell where my ambulances were at any given time. If they broke 80 miles an hour, I would get a bing. Okay, they were not supposed to do that. So if they were mad at me about something at 3 o'clock in the morning, they would hit 79, 81, 79, because every time it crossed 80 going up or back, my phone went off. My wife was mad as hell. So I just smiled. As long as they're having a good time, I'm okay. So out of this one, I want you to get this. This was the last takeaway that the folks from UGA, this was their last slide, I think. I want you to get this: state level leadership to promote equity, efficiency, and education. You can tell their college people. So and I'll come back to that. One of the problems, wall time at hospitals, it's not unusual, say 3 or 4 hours. If you're that 1 or 2 ambulance service and your 911 truck's on a wall at a big hospital for 2 or 3 hours, that's a problem. Work fatigue, I know one county that is a problem. They've got 2 crews, not 2 crews on a given day. They got an A crew that works today, a B crew that works tomorrow, then A crew comes back. Okay, can you survive that? What happens if somebody gets sick? It is a problem. Salary, they make about half of what a new 2-year RN makes. That's a problem. But now, having said that, there's some county governments out there that are paying paramedics $100,000 a year. I wish I was young again. They won't hire me, smart people. So assistance in training, a lot of the technical schools giving up the EMS training altogether that don't do it. Bullitt County does. In our area, Southeastern Tech does it. They've got an excellent program. But when they merged the tech schools together, guess what? They took their EMS program back to the mothership. So if somebody in Manuel County wants to take an EMT class, then they've got to drive 70 miles a night back and forth 2 nights a week to become an EMT. Okay, at the pay we give, it's kind of hard. Understand something, I never intended to be where I'm at today. Okay, I'd gone through a good divorce because I finally married my wife, who I love very much. But I'd gone through that, and I was doing some things that my mother did not approve of. And when a guy named John Pascoe came in one day and said, "Why don't you take the EMT course? Won't cost you but $10." What went through my mind was it would keep me sober 2 nights a week. That's the type of kid I was, okay? So I took it, I finished, passed, did all those things, went back to work with my dad as a mechanic. And several months later, he called me and offered me a job. So I took it. And that was it's been right at 49 years ago, all right? I think I told people I would do it till I got good at it. I gave up, okay? Oh, this is kind of important. because training costs now falls on the local government. So if you can't get to training and they won't go there, you do it locally. My hero there is a guy named Terry Cobb. He's over in Lawrence County. They do 2 programs in the community and 1 at the high school. Terry's one of the few people I know that's got a completely full staff because they have organically grown it themselves. We do the programs in Emmanuel County. We, at the Trauma Commission, we fund 45 of those classes every year. So they can apply, and they're geared towards rural communities. They can apply to us. We will pay the cost of them doing that class. So here's another good one. And this one is a little bit also, I'll have to explain. This is the paramedic. If you notice the difference in numbers, the number's 36. All right? So we netted an additional 36 paramedics that year. Now, if you really dial down through it, you'll realize that this was a research year, okay? Failure to renew, all right? Several hundred failed to renew, so you really have to add that number to that 36 to get the number of actually increased. But now you divide that from 159 counties, that becomes difficult. So legal consideration, a lot of liabilities if they don't transport, so they end up transporting. And if they're a rural without a hospital, now that's going to take them out of their county for several hours, and they're worried about that. So do you know who's taking care of your patients? I know a lot of hospitals that don't have a clue, the qualifications, and this one is, I absolutely agree with. I trained to use the hang blood in 1976, okay? We didn't initiate it, but we hung. Now you got to take an extra class to do it, all right? You know how many services in Georgia have taken that class? Last time I checked, 17. 17, that's embarrassing for my profession, okay? Local rules. County commissioners are good people. I love them, some of them, most of them. They'll write a contract that says you got to have X number of ambulances in the county. There's a lot of private services there. Our hospital is contracted with the county to run it. And they do that for a good reason. They think they're protecting the citizens. But if you got a patient in that hospital who's been involved in an automobile accident or a gunshot, and they're bleeding to death in that hospital, and you think that you shouldn't transport them because you're waiting on another call, you're just wrong. You're just wrong. And I tell everybody I can, you're just wrong. If you're waiting on an emergency when you got one laying in the ER bed, you're just wrong. And they need to fix that, okay? They get into arguments about payment for indigent transports because it costs a lot. And then it's not my responsibility. A lot of county commissioners say if they're in the hospital. A lot of EMS directors say if they're in the hospital, they're not our problem. I had a conversation just several weeks ago with a fire chief in a rural county. He said, Courtney, they're in the hospital, they're in a stable environment. I said, if they got a STEMI and their heart muscles dying, they're not in a stable environment. If they get to a cath lab, my friend I was talking about a while ago didn't have a heart attack. And you're saying, Courtney, yeah, you just told us he did. The definition of a heart attack is myocardial muscle dying. He didn't have that because we got him to a cath lab. They cleared the blockage, and he walked out. Okay? My little takeaway on that is, if we had not done that, let me make sure it's not on the other slide. I don't want to get ahead of myself. So I'll come back to it because it's a good point. There's tremendous disincentive for an EMS to run a good service. Go back to my friend who we picked up and took to Fairview Park. If I was a businessman, then I would have said, bring him to our hospital. Then later we would transport him to the cath lab. 2 trips, twice as much revenue for me. Our hospital would have made a good bit of revenue also out of that because he had insurance. Who would have lost? My friend would have lost. So who gained? Obviously he gained because he's alive and doing well today. The other people who gained was the healthcare payment system. Because when I did the research then to care for a person with congestive heart failure, and if he had lived, the doctor told me he would have had enough muscle damage that he would not have gone back normal. At that time, it cost $100,000 a year to care for a congestive heart failure patient. That's 8 years ago. I can do the math. That's $800,000 at one patient. So Emanuel County pays a lot of money to buy that equipment. The healthcare system saved $800,000. If you're a businessman, you buy LifePak 5. If you can find batteries for it, you can still get the same payment for Medicare, Medicaid, and insurance. There is a disincentive. Rural Healthcare Transformation Fund, that is in the big beautiful bill. That's that $50 billion put there. We're hoping that as it comes to the legislature, y'all will help get that into the rural areas because it's hopefully designed for that. Solutions. This is not a direct quote from what I gave you a while ago, but this is a quote from the 1966 white paper developing EMS. It takes thoughtful planning. It takes local, state, and federal levels cooperating to make this work. That's who I am. I'll answer questions, or you're probably hungry, and maybe I've made everybody mad.
Questions?
I'm John Odom. I think everything you said is absolutely true. I enjoyed hearing it. I hope that the committee would take some of his numbers back and some of his slides in the final report. I work at a rural hospital and a tertiary care hospital. I don't have any beds. So I get called from a rural hospital, and I finally got him a bed. Let's say not an emergent case, but an urgent case. So the patient doesn't show up. I've got 40 patients boarding in my emergency room. So I call the rural hospital and I say, what in the world? They go, the ambulance is not available. And so what you said is far-reaching on multiple levels, not just trauma. It's very difficult to get a patient transferred to a tertiary care hospital in Georgia. I'm pretty loud. Thank you very much. I enjoy it.
Thank you.
Good. Okay.
And those slides, anything on those slides you guys got, ticket for you to get them, use them any way you want.
We do have a question, Representative Hagan.
I don't know if it's going to turn into a question, or I'd just like to share some observations I've made locally and maybe get your thoughts on it. Whenever I'm talking to administration or medical staff at any of our rural hospitals, the two things I hear that they are most concerned with are, one, that patients use the emergency department as their primary care. And the second one is always transport, always. Patient transport so that we can move, not initial transport to the hospital. That's not been a problem, but getting our constituents, my constituents, from the hospital to a higher level of care because they need it. And I'm very tuned into this because my husband's in administration at our local hospital, and so 1 week out of every month, he's the administrator on call, and I usually wake up in the middle of the night at least 2 or 3 times that week, hearing him try to get someone to pick up a patient and get them to Savannah or wherever they need, usually Savannah. And we've got people that are dying in the hospital needing to get care, and he can't get them moved. And So I'd just like to hear your further thoughts on what we can do, how to fix this problem, because I hear things like, well, they're having wall time in Savannah, and that's time away from our county when we have trauma situations, and I understand that, but like you said, it is a trauma situation when somebody's in your hospital and needs care, and they're going to die without it. So will you just comment further on that for me, please?
My thing is that it was designed in 1966 and it needs to be redesigned. There was a group, and there's the Rural Health Department, Office of Rural Health, Nita Ham, who's one of my heroes. They have done a survey of all the rural hospitals on transportation issues, and I think that's going to be made available to you. I don't know if they've finished all of their studies on that or dialing down, but I think it's going to say the same thing that I said today. The thing I would tell you is that it's resources and attitude. And the resources in many rural communities are just not there. And most commissioners, that costs too much, and it does. But a lot of the problems with cost has to do with economies of scale. If you've got, somebody's mentioned communities with 2,000 people, you can't do it. I mean, you can't, because your fixed cost is going to be at least a crew, an ambulance, insurance, that equipment. That's your fixed cost. And if your volume is not enough to start beating against that fixed cost, somebody's got to pay for it. In some places I get almost run out of the room when I'm saying that rural communities should be paid significantly more to do what they do. If I pick up our ambulance service routinely picks up patients at trauma scenes and takes them directly to a trauma center. Why do we do that? Well, first of all, they get better care quicker. Second of all, they don't have but one ambulance bill and don't have another hospital bill. That's the other thing. But the biggest thing is that's where they need to be. That's where the best care is going to be. The cath lab, I was at another hospital they asked me to come because they brought their county commissioners in, and they were going to talk about this because they had the same problem. And after the commissioners left, the nurse said, well, they should have known what happened last night or this morning. I said, what happened this morning? Well, we had a patient in with a STEMI at 6:30. We called that ambulance service, and they wouldn't transport him. The cath lab was 45 miles away. 6:30 in the morning, they had 3 crews. There's no way you're going to convince me that they were busy at 6:30 in the morning. I know what's going on. At 6:30 in the morning, they just didn't want to get up and make that transfer. And I got mad. But right at that moment, I got mad at that nurse. I said, why didn't you tell that commissioner that? And I've got folks who tell me that, well, they're in a hospital, they're not our responsibility. Commissioners tell me that. So I said, okay, so he's a citizen of your community. He pays taxes in your community. He loses that citizenship right when he walks through the door of a hospital. I stay frustrated. I'm sorry.
Dr. Sumner.
Thank you, Courtney. I know the great work you've done for years. We live in adjoining counties, so we've lived in adjoining counties, and I have a great respect for your work. And I think you mentioned this, but the data you showed was from the trauma centers and their opinion on what needs to be done. But you do have data, or do you have data, or a survey of the leadership and the people who are doing the work at rural hospitals as well, and at transfer hospital?
This was leadership of the level 3 and 4 center.
Yeah, but the rural, did you survey the rural ones?
We have not, but it's my understanding that last legislative session, a group of us worked with Senator Bo Hatchett because he was looking at funding a study committee to see how we can resolve this. And to be very honest with you, it's very difficult. It's a very complex issue. 159 counties, they don't do it except for these several services that run multiple counties. And so we walked away from it. But they had developed a survey to look at it. They did that survey, but I haven't seen. I'd love to see the answers there.
I think looking at that's important, because I think that it is sometimes attitude. You know, it's sometimes insurance companies. It's sometimes, you know, frustration. I was involved in a call the other day where there were 50 people waiting in the emergency room, and they wouldn't even talk to you, but it was the closest place, you know.
Yeah.
So really drilling down and looking at those rural hospitals and asking them what they could do better and seeing if we could come up with a solution based on facts. I think that would be critically important. I know Dennis Ashley, one of his residents, did a study during COVID where they looked at head trauma, cerebral hemorrhage. I'm sure you're familiar with it, where I think there was 114 patients that were transferred to his hospital and went to the ICU. And retrospectively, they looked at it, and of the 114, I think 2 of them really needed to be transferred, but the local hospital was scared, and understandably, I would have transferred a cerebral hemorrhage, you know, but if they had had telehealth and had the neurosurgeon look at those people locally and monitor them, that would have negated those transfers to a hospital that needed those beds for COVID. I think that it's a complex problem, and you're right, but thank you for what you do.
And to your point, Dr. Sumner, the REACH program, which is a stroke program that we're involved in our hospital, has worked great. And there has been some attempt and some interest in doing that. In that study, some of the slides talk like they would want to do that. And that's why I was pointing that out. I think at least pre-hospital, we got some capabilities to do that. And if you can, quite frankly, if you can keep the person, a lot of the people that we take with trauma walk out the ER that day, because it's very difficult pre-hospital to get a great understanding of what's going on. So if you could bring them to the local hospital, do a CT, MRI, and say, hey, they don't have a bleed, they got a headache, and you might save a helicopter trip.
Well, the work you do is critically important, so I appreciate you a lot.
Thank you.
Chair Lady Taylor.
Thank you, Madam Chair. Thank you for this presentation. It is vitally important. I think we overlook that transportation piece as part of access. And I'll share one of our small counties. It wasn't that little bitty one, but it's one with 2,000, 2,500 lives. A man had a heart attack out on the lake. There's no ambulance service in the county whatsoever. He rode 40 minutes in a hearse. They stabilized him as best they could and got him in a hearse and had to get care there. He did make it, but that was by the grace of God, because there was no service. I think something we need to look at is to do, as you said, regional. We're going to have to do intergovernmental contracts to find a way to provide this care. I'm not sure how does it make a difference for you, or when you see it in action? If it's a county, my home county, actually operates our ambulance service, but counties beside me do not. They have private practitioners or private companies that actually do it. We also had a county I used to represent had one ambulance, but the floods came and you couldn't get across the bridge, and so people on the other side had no service until you went 40 miles out of your way. It's a big county. So there's a lot of things we need to look at, and you're right. Planning is going to be a big piece of it, but this really is an important piece of access. Thank you.
Yeah, imaginary lines are a big barrier. They really are.
Representative. I missed just the first part of that presentation. I had to step out, but I ran into this several years ago. I was flagged down on the side of the road by a friend of mine, and where I live, there's a lot of pig trails that are paved, but they're not much more than pig trails. The county I live in is Coffee, which is 600 miles of dirt roads, 400 miles of paved roads. So very, very rural. So anyway, I got flagged down. There was a car accident on a curve. The driver was DUI. He had been ejected, multiple injuries. 2 children had been ejected. One had multiple fractures, obvious multiple fractures. We were concerned about internal bleeding. And so she and I were trying to keep these people alive on the side of the road, beating ants off of them. The sun went down. We waited an hour and 15 minutes for somebody to get there, because we were in this little union where Coffee, Irwin, and Ben Hill come in together. Nobody could figure out jurisdiction. Their GPSs weren't telling them, getting them to the right place. She and I were literally about to lose our minds. At this time, all other people are coming up, trying to figure out the jurisdiction and who's going to transport. Nobody could get there. I said, I don't care. Send an ambulance from every county. I don't care. So finally they did. We got a helicopter on scene, but it just took forever to get the response time. Thankfully, by the grace of God, we were able to keep them alive. But I was curious because we were also being told that the ambulances were out. So it made me think, what is the basis for letting a county figure out how many trucks they have and how many people they have on EMS? Is that based on population, or is it merely how much we're willing to pay?
That's more of that second than anything. There's one of the things we've tried to do is look at, and again, it's a complex situation. So Manual County staffs, with the extra volume there, they staff 2.5 trucks. So during the day, they have 3 trucks, and at night they have 2, because at night the volume's not there, and it's just more economical to do that. I know some counties that have got, same size county got 12. They got more money. They're willing to spend more money at it. There is, to my knowledge, no rationale and no algorithm about how many you should have.
Isn't that bizarre?
It is. It is. In today's world, with the research, the GPS things that we got in our units, if the state office wants to turn it on in their office, they can know where every ambulance that's got one of those devices are, where they're at, how long they've been there, and with computer algorithms, we could figure a lot of that stuff out. Ambulances are based in political. We did a study several years ago, worked with State Office of Rural Health, and surveyed a bunch of county commissioners. You know, what would it take for a county commission to put 3 or 4 counties together so they could develop that economy of scale? And they did the survey, and it comes back to me, it was one word: autonomy. Every one of those commissioners wanted to tell their ambulance service where to be, what to do, how to do, and that's what happened.
But they're not. Oh. Thank you so much.
Thank you so much for your time.
Thank
You
you.
certainly have brought a lot of information to us today.
And if you want the slides, just ask Leo and use them any way you care to.
Very good, very good. Members and staff, we will take a lunch break and come back at 1:30, so if you all can eat just a little bit faster. We have 2 more presentations from the Department of Community Health and the Department of Public Health. With that, we will stand in recess. would like everybody to take their seats so we can start the second half. Very good. I hope everybody had a good lunch. I am going to introduce the president of Georgia Southern, Kyle Marrero. Thank you so much for having us.
Thank you, Madam Chair. Thank you so much, Madam Chair Donatucci, and thank you so many friends here that I see that are here today with us doing this great work. And I have to tell you, this is a work of collaboration and partnership to serve the state of Georgia. As educators, as an institution, and I know my provost this morning was able to talk to you a little bit about what we do, particularly in the health professions space, and we're so proud of that with over 6,000 majors in our Waters College of Health Professions. One of the stats that he may have shared with you is 1 out of every 5 undergraduate degree in health professions in the state of Georgia is a Georgia Southern graduate. We are one of the largest producers of radiologists, of BSN nurses, of across the board, of physical therapists, et cetera. And our goal is to continue to grow that and serve our state, particularly in our rural areas that need so badly the health care that you all, I'm sure, are addressing here today, and thank you for that. I know Avi also told you probably about today is our first day of classes, and so we've been running around. I get to meet 2 freshman classes here right after you, so I'll try not to get my talking points mixed up. But at the same time, when I tell you for today, it is a record-setting day with record freshman class in the history of the institution, over 6,000 freshmen, and I think Avi told you just short of 30,000. Actually, as of this morning, we are 30,282 students registered at Georgia Southern, up 9.2% from last year. But most importantly, the work that we do in this state to prepare graduates to serve us, particularly in the health sectors, is critically important. And for us, we take that seriously, and we certainly look to the outcomes of this report to help direct us on how we can serve you better. And for us to have people here that are partners already, Jenny Wren Denmark, and we've already established some partnerships with Jenny Wren here in our region, serving at our East Georgia State College campus, soon to be Georgia Southern campus. Of course, you all know Angie, who's our doctor here at our medical center here on campus. And so the people associated with Georgia Southern, and of course Chairman Butch Parrish, who has been such an incredible supporter of us, of what we do here in this region. We're ready to answer the call. We are doing it already, but if there's gaps and needs, we are ready to move forward quickly and efficiently and at what we say, the speed of business. So call on us when you need us, and know that you are always, always welcome here at Georgia Southern University. Take care and have a great day. Thank you all.
So we'll be starting with our first group, the Georgia Department of Community Health.
Hi, everybody. Good afternoon. Thank you to the committee for allowing the Department of Community Health to come speak. My name is Emily Yona. I've been with the department for about I guess a year and a half, a little bit over that, and had previously met many of you in a different role, but been at the department. Just a little bit about the Department of Community Health. Our current commissioner, as of 5 days ago, or what day are we? 14 days, excuse me, August 1st, is Commissioner Dr. Dean Burke. So many of you may remember him from the Senate, but also he was an OBGYN, and he also ran a hospital in rural Georgia. But this committee is near and dear to his heart because he has been a lover of rural Georgia for quite some time. So just wanted to start with that. Department of Community Health does a lot of different things when it comes to the state of Georgia, but kind of high level, we oversee Medicaid, the State Health Benefit Plan, Healthcare Facility Regulation Division for any state-run facilities, and then health planning, which is really a certificate of need process. But today I'm here to talk to you at the request of Madam Chair Donatucci, Georgia's Pathways to Coverage program, which was part of Georgia's Patients First Act. So we're going to talk about that today. And this really provides health coverage to, it's really a Medicaid program. What's interesting about this program is Georgia's one of the only states to pull this off, and now based on the big beautiful bill, H.R. 1, we are one of the only states that's ready to implement that because we've already done it. We are really leading the charge in the country with pathways. Governor Kemp had that insight to do that. So just our purpose here. So a little bit about Pathway to Coverage. So as I mentioned, Georgia's Pathway to Coverage program was part of the Patients First Act, which Governor Kemp signed in March of 2019. In that bill, it granted the Department of Community Health the authority to submit a Section 1115 waiver with Centers of Medicare and Medicaid Services, CMS, to apply for a waiver, basically waiving some of the rights, some of the pieces of what a normal Medicaid expansion would be. Really, the purpose of an 1115 waiver is to pursue innovative strategies and to test different approaches that promote the objectives of a Medicaid program and to provide access to high-quality, affordable health insurance. As many of you, I'm sure, know, Medicaid is actually a state-run program, different than Medicare, but with a Section 1115 waiver, it does allow states to kind of build innovative programs, as I mentioned, and that's what we did with Georgia Pathways to Coverage. So I think before we talk about the pieces of, explaining what Pathways to Coverage is, it's important to talk about our timeline and how it all got started. So as I mentioned, Governor Kemp signed the bill, which allowed the department to apply for a Section 1115 waiver in 2019. We actually sent up the waiver in December of 2019, and CMS approved that waiver in October 2020. That was for an implementation date of July 1 of 2021. That was when the waiver was supposed to start. And I think that's important here just for context. We were given a 5-year waiver starting July 1 of 2021. However, due to the administration's decision at the time, they revoked that waiver in December of 2021, therefore putting the program on pause. And why that's important, you'll see later, is because we're only 2 years into the program when we will be close to 5. Georgia filed a lawsuit to get that decision overturned. Through court's decisions, we finally did have that overturned, and so the program actually started of July 1 of 2023. So we're about 2 years into that program, and I think that's important because it's still a pretty new novice program that we're still getting started, and that's why that's important to kind of say. The other thing I'll mention in this timeline is we also were dealing with redeterminations. So why that's important is during the COVID-19 pandemic, the federal government decided that no one would come off the Medicaid rolls and no one's eligibility would be run for Medicaid. So at that time, 2.6 million people were the highest point of Medicaid in Georgia of people enrolled. Fast forward after the pandemic, not saying the pandemic was done, but when the federal government came down and said, okay, now we need to start doing annual redeterminations on all of these individuals. It is the same IT system that does the redeterminations and the initial application. So kind of talking about eligibility, it was everyone all at once. April 2021 was when redetermination started. As I mentioned, the state had to run 2.6 million people through the redeterminations process as well as implement this program. So kind of just a journey of what's kind of been happening with the Department of Community Health and what's happening with Pathways. With that, we actually successfully pulled off the redeterminations, have successfully pulled off Pathways, and we are well on the way, like I said, 2 years into the program, and it's showing a lot of success. So what is Georgia Pathways to Coverage program, and what does it cover? So really, Georgia Pathways is, and Governor Kemp intended for it to be this way, it is a pathway for people to get on private insurance. So it is for those currently not eligible for Medicaid, ages 19 to 64, so not children and then not elderly adults, that are under 100% of the federal poverty level. For those individuals specifically, it provides a pathway for them to get Medicaid coverage. They must meet a qualifying activity requirement of 80 hours per month, and they must be an American citizen or a documented qualified alien. Go next into what are considered qualifying activities. So, as we mentioned, this is unique, one of the only programs, but Governor Kemp intended for, like I said, this is a pathway to private coverage. And we'll talk a little bit about that at the end of presentation, how this Georgia's Patients First Act included part of that in the end. But as far as what is a qualifying activity and what do we consider today, as of today, it is employment, including self-employment, on-the-job training, job readiness, community service or volunteering, higher education, either through a USG institution, private institution, or TCSG institution, and then, or you can be participation with the Georgia Vocational Rehabilitation Agency. What's interesting is since we've kicked off the program and being at Georgia Southern, we've actually seen one of the highest enrollment groups be for college students, both on the TCSG side and the university side. It's actually a population that I don't know that we all thought about, but it does provide that coverage as someone when they get into college to have some health coverage here, because like I said, they just need about 80 hours per month for a college student is about half-time enrollment. So as long as a student's enrolled half-time, they can get pathways to coverage. So those are the qualifying activities. Like I said, the goals intended by Governor Kemp and by the Department of Community Health are to improve the health of low-income Georgians by increasing access to affordable health care coverage, reduce the number of uninsured Georgians, promote member transition to commercial health insurance. And this is where I was talking about it's a pathway to private coverage. Important to note. Empower Georgia Pathways participants to be active participants and consumers of their health care. Like I said, there is that qualifying activity component, and that was important to Governor Kemp to make sure they are an active participant in their health care and in their lives. Increase the wage growth of those who are employed, and it ensures a long-term fiscal sustainability of the Medicaid program. This one is key, and today I think we've seen we're all aware of, federal government and all what's going on up in DC and the want to, make it so we're not continuing drawing a deficit down. Governor Kemp and previous Governor Deal had that insight, I'll just mention, and Governor Kemp wanted to make sure that if we built a program that did, allow adults to get on Medicaid, that it was sustainable for the state, it was fiscally responsible. So I think it's really important to talk about where we're at today with Pathways and the renewal. So as I mentioned, it was a 5-year waiver, which means that this current waiver actually expires on September 30th of 2025. DCH has submitted a waiver renewal for another 5 years, but we made some slight tweaks to that in April of 2025, hoping for another 5 years to renew the Pathways waiver. We made some tweaks based on Governor Kemp wanting to make this, like I said, this is a demonstration. This was a waiver. This was to try an innovative thing. And these changes came from what we've identified and what the state has identified as potential how we can make the program better. So the two I'll really highlight, and all of this I think we've handed out slides, but the two I'll highlight is we have a change to annual renewal of reporting for qualifying activities. This program intended to do monthly, but we found that it was just with our IT systems, it made more sense to do annual renewal because right now the rest of Medicaid is an annual renewal and an annual kind of checking of reporting for requirements. So we are trying to align that with our other Medicaid program and normal Medicaid. The big one, which I think brought a lot of excitement, and this really does have a lot of goals in mind that y'all really supported with like maternal health and supporting of caregivers is with the renewal, we are hoping to add an additional qualifying activity, and that will be parents and legal guardians of children under 6. That'll qualify as their qualifying activity. So any caregiver, legal guardian of a child under 6 until they essentially go to school, they can get health care coverage if they're under 100% of federal poverty level. This is, we had some public hearings, and like I said, this is also in line with, I think, a lot of the goals that the legislature set, as well as the governor, for kind of that momentum around, coverage for maternal health and that sort of thing. So there's some other kind of nuanced pieces that one was retroactive coverage policy for helping with the application period, and really the removal of premiums and member rewards accounts. Those are two things that when we started the program we really thought would be beneficial, and it's turned out that they're not, so we've decided to just take them out of the renewal. We are currently still waiting on CMS to approve this renewal, and so these are still to come, and I know there's a lot going on in DC. So we're still waiting on with the renewal. We talk to CMS a lot, and we do think that Georgia's well positioned. Like I said, we're kind of the model for the country right now as a state that has pulled this off. And so we're hopeful we will get a renewal very soon. As I mentioned, that's kind of Georgia Pathways, and that's really what my Department of Community Health, oversees. The other piece of that, though, is that I think it's important to highlight in the Georgia Patients First Act is Georgia Access. And I am not from the Department of Insurance, just to be very clear, and Department of Insurance is the one that runs this. But I really wanted to talk about how Governor Kemp intended for pathways to have, like I said, a pathway to private coverage. And while that's important is Georgia Access. So basically you'll see on the screen that there's the traditional Medicaid coverage. And that is your traditional age, blind, and disabled. Then we have pathways for the able-bodied adults that making up to 100%. And then you've got Georgia Access. So this is, and you've probably, I'm sure there's a lot of good media around it, the state-based exchange, where Georgians can go and apply for private health insurance from 100% above. Any Georgian can do that, but starting at 100% of federal poverty level, they get subsidies that can essentially provide either free or very cheap health insurance to them. The next slide will show you. So what's important is the highlighted document on one side. So basically, if we stop at 100% of pathways, the important note here is that currently, and this is based on 2024 because I believe the Department of Insurance has not done 2025 numbers yet. They'll do that after open enrollment. But 100 to 38% of federal poverty level is what is a normal 0 to 138% of federal poverty level is what usually would be in an expansion state for Medicaid expansion, and that's what we all know as other states. As I mentioned, up to 100% is Georgia Pathways. They have that ability with a qualifying activity to go get Medicaid coverage. On Georgia Access, between 100 and 138% of the federal poverty level, there are currently about 710,000 people on health insurance. Private commercial health insurance that is fully subsidized, that is 100% covered. So with Georgia Access, currently, between 100 and 150% of federal poverty level, they have fully subsidized health insurance, which means zero. And you can see up here on the right side of where that breakdown is and how that's a sliding scale for Georgia Access. So therefore, with the pathways and Georgia Access, we feel there's a full coverage for every person in Georgia. That I think is really important to note, though, on the decision to not expand and really Georgia's Patients First Act, and how it kind of all works together. Like I said, I'm not with the Department of Insurance and cannot really talk a lot about Georgia Access, but I will. I just think it's really important to note that that's kind of where we are today. 710,000 people that are getting fully subsidized health insurance through a marketplace or a private health insurance plan. So that is all I have today for you. Glad to answer any questions. I think it's still, we were trying to get the word out, but it's still a novel program, and you've seen the challenges we've had for it. I know some people are probably sick of hearing about Georgia Pathways, but I think it's good for everyone to hear it just one more time. So,
any questions?
I'm sure you are too. There's been very few people enrolled. I'm wanting to think around 6,000. Maybe you've got new numbers. What are you guys doing to get this out there better?
So I think one thing we've really tried to do, and I appreciate your comments, one thing we've really tried to do is talk about pathways in conjunction with Georgia Access, because I think the two are together. Because I think when other states talk about the population that is eligible, they're thinking through 138% of federal poverty level. They're not thinking through 100%. And so when you think about 0 to 138% of the federal poverty level of what would be covered, we're looking at over 800,000 people that do have health insurance. That's really for us. Governor Kemp really intended for pathways to be, like I said, a pathway to private coverage. And so the goal has always been not to get on pathways and stay on pathways. It's to let those people, improve their lives through job, work, volunteering, whatever that is, to then get them on private insurance. I will say, though, like I said, with this being a novel program, and the start and the stop of everything. We've really worked and spent a lot of money on investing in the IT systems to make it better and make it easier to use, and the marketing to make sure people are aware of the program. We're still out there at town halls every day educating people about Georgia Pathways.
I think one of the bigger problems is a lot of these people don't know or care. They get their care out of the emergency room, as we've heard elegantly put today, and some of them don't have computers. So I honestly think more than electronic technology, it's probably going to require a grassroots movement to get people to apply for this.
100, yeah.
I would say 90% of the people that might qualify hadn't heard of it, nor will they.
So that you bring is a very good point. And so that's one thing the department identified. So we are actually attending community events. We have our staff out at events, actually in partnership with Georgia Access. And so we're gonna even increase that at community events. You're 100% right. So one thing we identified is we actually have someone from DCHRA, someone talking about pathways, but also eligibility is run through DFACS and DHS, and actually having in partnership them there that can actually do an application at community sites. We're also building partnerships with hospitals, because we know the reality is if someone shows up to a hospital in an emergency room, doesn't have health insurance, is that a place to catch them and then offer this as a option? So we're really, I mean, we will take all the help, like I said, a novel program, and we are actively trying to improve it by every day, you know, that we are trying to help that. But if you have ideas, we're always open to them as well.
Representative Hagan.
Thank you. Real quick, did we have any idea when we might hear about that waiver application and when a decision might be made on that?
Any day. I know conversations were being had today that we have basically biweekly calls with CMS, just so you know, to discuss this. And we're really hopeful. Like I said, Georgia Pathways is a model for the country. We've been told that. We know that as it was moving through HR 1. So we're really hopeful that we'll get an approval soon, but it's really any day. I'm not a betting person, so, but yeah, it's so far everything looks like it's going really well.
Chair Lady Taylor.
Thank you, Madam Chair. Thank you for the presentation. I appreciate that. And I did want to share that there have been some innovative hospitals that have made arrangements when they have someone that shows up with no insurance. They're giving them a choice of several people. Here's some brokers, here's some people that can guide you where to go get coverage. And I think you're going to see a pretty good jump in that participation. They've caught on to it because it makes a difference for the hospital. It helps them, but then that person will be able to carry on their coverage and get their treatment that they need. Thank you.
Thank you.
Any other questions? Thank you so much.
Thank you.
Now we have the Georgia Department of Public Health discussing telemedicine.
Hi, everyone. Happy to be here today. Thank you for having me. I'm Megan Andrews. I am the Assistant Commissioner for Policy at the Georgia Department of Public Health. Today, I'm going to be talking about services that are available through health departments, as well as our telehealth coverage that we have within the state right now. Here's a slight overview of what I'm going to be covering. First are core public health services that are available in all health departments. So these are things where you can walk into any health department and get these core services. A comparison of the services that are available at a more urban health department versus a rural health department, because they do vary. Capacity issues within these health departments, as well as telehealth. So to start, I'll explain a little bit about the public health structure in Georgia, because I think it'll provide some helpful context. So we have one state office of public health. We're right across from the Capitol in Twin Towers, overseen by Commissioner Dr. Toomey. We are broken up into 18 public health districts. You can see by the different colors in the map. And then there is a physical health department location in every single one of those counties in Georgia. That is overseen by a county board of health. So in Georgia, we operate under what they call a hybrid structure, where there is both state and local control over the health departments as far as what services are provided within them. So as I mentioned, here is a full list of the core public health services that are available within every health department. So all 159 counties, you can walk in and get one of these services. And I'll talk about some differences between the urban and rural, and on as far as like scheduling. There may be days of the week where you cannot access these services because we don't have a clinician on site that day. But they are offered at least a day a week. So I can go into that a little bit too. But a few to highlight are children's services. So we have several programs that assist children. Children's First is the single point of entry for children needing additional services. So they go into Children's First and can get referred out to a whole suite of programs that may assist them with their needs. Babies Can't Wait is an early intervention program that provides services to children that have 0 to 3 is the age we cover, that have developmental delays. So typically it's speech, PT, OT therapy that's available in every health department. And actually Babies Can't Wait, they come to the child. So they'll usually provide the services in the child's daycare center or at their home setting. We also do children's medical services, which is case management and oversight of medically complex children, and that is important for me to highlight here because it goes to our telehealth services. They're primarily used by our children's medical services program. The other ones I want to touch on is WIC. This is the Women, Infant, and Children's Program. It's a federally funded program that provides nutrition support for pregnant women and young children. And then our environmental health services program, which when I go to a slide about our funding, you'll see some differences there, but that's everything from restaurant inspections, hotel inspections, animal bites, lead investigations if a child has lead poisoning. So the environmental health program covers a lot of area to protect the health of Georgians. So based on everything that is going on federally, I thought it was important to share with you all a chart showing these core services and their fund source. For the most part, most of our programs have several fund sources that they cover. The only two that have exclusive funding is our WIC program. It's pretty much all federal funds. There are some revenue generating funds that are retained at the local level. And then our environmental health services has no federal fund contribution. It's a fully state funded program, as well as some local dollars. And if anyone is interested in learning more about public health funding, you should definitely come to Chairlady Taylor's committee next week. She's hosting a study committee. So we're gonna be going over all of this in much more detail, but based on the federal landscape, I thought it was important to kind of lay out the various fund sources. So the state funds is obviously from the legislature. Federal funds come down as grants generally. Other funds are could be like fee-generated revenue. So that's like restaurant inspections, they charge fees. They're able to retain those fees to then go back into the program. Another example is insurance reimbursement. So if we bill for insurance, we can retain those reimbursements to come back into the program. They wouldn't fall into any of the other buckets of funding. And then the last one is local funds, which is the county's contribution to the operations of the health department. So taking a look at an urban versus a more rural health department, I chose these two because they're within the same health district. As you can see, the coastal district goes from Effingham down to Camden County. So that way they're within the same management and oversight in that regional structure we have, but you can see the differences in staffing, services offered, and all of that. And a lot of that goes to the fact that there's that fee-generated revenue that the counties then retain. There's a lot more restaurants that are paying inspection fees and the Chatham County area as opposed to McIntosh, and then as well as the county contributions. They vary greatly depending on the location of the health department. So if in a more urban health department like Chatham, here are some additional services that are offered beyond those core services that the health department is required to provide. They have a vital records office on site where you can get birth certificates. They have a car seat program where if there's a low-income family that needs a car seat for their child, they can access it there. They also have a dental clinic to provide those services within Chatham. And then the last one, too, I want to highlight is the PrEP program. PrEP is, for those of you that don't know, it is a medication that individuals take if they have high-risk behaviors to prevent them from contracting HIV. So the best way to compare it is almost like a birth control that you take every day, and it protects you from getting HIV. And I'm highlighting that because I'm going to cover it in our telehealth slide too. So comparing the two side by side, you can see that in McIntosh we have one physical health department location, whereas in Chatham there are two health departments and then also an HIV care center. And then the fourth bullet down, there's services 5 days a week in Chatham, whereas in McIntosh there may be certain days of the week where there's only 1 day or 2 days that offer services. For example, LARCs, they're long-acting reversible contraceptives, IUDs essentially, and we need an advanced level practitioner to be there to insert the LARC, and we don't have one on site in rural counties every day of the week. So they rotate through the counties within their region to try and make sure there's at least access at 1 day a week within their area. So, okay, so some of the challenges that I talked about, as with all health systems, we have challenges with workforce, recruitment and retention of staff, especially nurses and environmental health staff, nutritionists. They're the ones that work in the WIC program and help coach families through healthy eating and dietitians. That impacts the type of clinical services that we can offer within the health department, as well as the days of the week or month that we can offer those services. And as far as environmental health, when we do have shortages of staff, it could increase response time for services. So if someone's waiting for a septic permit, it may take longer than we hope if we're short-staffed. And looking at the staffing comparison, there's 100 FTEs in the Chatham Health Department and only 5 in McIntosh. So you can see a huge impact that could happen even if we have one person that is leaves for whatever reason, retirement or otherwise. It could definitely have an impact on the service delivery. As far as telemedicine access, I mentioned in the previous slide that Children's Medical Services program that we have where we help provide case management and oversight of the care of medically complex children. That's primarily our focus and use of telemedicine. There's a few others that I'll cover as well. But within these counties, or these districts, there's the total number of counties that are covered. They have special needs clinics where we use telemedicine services within the health department to then connect these families to specialists so they don't need to travel to go see these specialists. And the next slide will give you a little bit more information. There's the list of our specialty clinics. So if a child in one of those counties that has telemedicine access, they can go to the health department and be connected to a provider at CHOA, Augusta, or pediatric genetics to get assistance instead of having to drive to these locations, which we know, and I know you all have talked about, transport is a challenge, especially in rural Georgia. So it helps cut down on the need for the families to travel to those locations. As far as other telemedicine services that are available, there are, and this is where there's that local control. We're not gonna have consistent services statewide other than those core services that I showed you. This will vary depending on the needs of the community and where they're prioritizing. So there are a handful of other telemedicine programs in our Waycross and Dalton districts. We do a lot of telemedicine services for HIV care, where we'll telemedicine consult a provider to help manage patients that are getting HIV services, as well as for difficult TB cases that we help manage. Audiology is another one that is available in the Valdosta district. I think the important thing to note is every health department does have the capability and the equipment to provide telemedicine services. The challenges are the interest of local providers to refer people to the health department to get these services, staff to help serve as like the originating site, scheduling appointments, getting patients set up for the telemedicine call, as well as finding the providers on the other end to answer the call. So those programs that we do have set up, we have contracted with the providers at the other end of the call to be receiving that on behalf of the health department as the originating site. Another program that may be of interest to you all, because you passed the teledentistry bill this past session, is we are one of the few entities that do teledentistry services in the state and have for many years. We go into school systems and provide school sealants for low-income children and exams and cleanings, and we'll telemedicine in a dentist locally to provide a consult for that child. So it's not, again, not in every county or district, but there are 2 districts that offer those services, and there's definitely interest to be expanding that. So that's also a telemedicine program that we're working on expanding. And then telehealth for PrEP. This is actually something that is in the department's strategic plan for one of our priority areas. So I talked about PrEP previously and how that's a service you could get at a larger health department. We do have one district right now that's offering telehealth for PrEP, but one of our goals is to expand that, hoping to expand it by 50% annually. And through that, the patient does need to come in for their initial labs, but after that, all of their care management can be done through telehealth, and so the goal is to have them utilize that as their mechanism to connect with a provider, let them know if they're having any adverse symptoms, and manage that patient's care until they need to come back in for labs again. So that's one of our priority areas that we're working on. And there is one, I'm gonna go off script for a minute since we have some members here that I wasn't expecting, but I did wanna highlight one other telemedicine initiative that was actually funded in the big budget this year by the House and its immense wisdom. The fiscal year 26 budget included $778,000 to fund telemedicine services for regional perinatal centers. So these are hospitals that serve as a hub within their communities to for individuals to access care. So they have like a maternal fetal medicine specialist there to provide care, and the funding for this will allow the health department to serve as telemedicine locations. It's like a hub and spoke model. So the regional perinatal center is the hub and the health departments are the spokes. So a pregnant person can go to a health department and then telehealth in to a specialist to get things like a sonogram or echocardiograms and have patient navigators managing all of this. So there's 5 RPCs that are going to be providing these services, and we're hoping to have 3 to 4 remote locations within each region of the state. So individuals don't need to drive 8 counties over to try and get services, especially for those high-risk pregnancy conditions like cardiac issues that has been one of the leading causes of maternal mortality. trying to increase access to the care in those rural areas. So that's something really exciting. We just got the money like a month ago. So we're really excited about that opportunity and are thrilled to be able to roll that out eventually in this upcoming year. So grateful for that always. I am available for questions if there are any.
Are there any questions? I have one if you want me to lead off. Are there any programs in place right now that you're using, any type of transportation?
So that is actually something that the commissioner is really interested in. We did talk about it potentially last year in the maternal health space, improving access to or transport for prenatal care services. That's one of the things we were looking at. Mississippi actually has a really interesting model that they've set up. We met with their health commissioner last week to discuss this, where they have contracted with Uber. And Mississippi rural areas are pretty similar to Georgia rural areas. And it was interesting where he said once they knew that there was a way that people would be able to be paid, Uber drivers started signing up in those rural areas. So that was an interesting take. We're exploring that and are going to be discussing it with DCH as well. But nothing available right now, but there's definitely some creative thoughts in the works right now.
Thank you. Anybody else? Questions? Dr. Sun?
I may be incorrect, but I'm told I'm the chairman of the Board of Health in Johnson County.
Yes.
Because I'm the only person there. I'm the only doctor there. But I'm told repeatedly that counties have to work with insurance companies to negotiate price on vaccines independently.
Mm.
And so we don't have much ability to negotiate. We're a poor county, we're a rural county.
Mm-hmm.
Why does the state not negotiate for the districts as a whole?
Yeah, that is a complex question, and we've talked about this. We actually talked about it yesterday with the commissioner about, we really should have a consolidated insurance reimbursement mechanism too, because right now all of the health departments have to contract with the insurance providers on their own. And the challenge at the state level because there was that lack of consistency. The other thing too that's challenging is there's the county board of health is its own entity, right? So the providers that are doing the services, they're county board of health employees. They're not state employees, they're not DPH employees. So when they're seeking reimbursement for services, there's some legal challenges with a statewide approach. And as far as that context goes, as far as the rates for immunizations, that's something I can talk to our vaccine program about and see if there's a way for the state to do that on the behalf of all of the health departments. But I know all of those reimbursement issues have been a challenge that, we're hoping we just awarded a contract for a statewide electronic health record system. So we're hoping with the rollout of that, it'll help bring some consistency, but it's a challenge. I mean, when I get a legislator request about, how many family planning service visits did you do, I have to email every health department, every district, and poll them, and then, add the responses up myself. There's not a way for us to go in and pull a query. So it is challenging, but we're hoping that IT system will help us improve a lot of things.
Chair Lady Taylor.
Thank you, Madam Chair. That's one of the things that, as I've looked at it, there's a difference between who's really in charge.
Mm-hmm.
And I think part of it is you have a local county board making some decisions, and some counties have more funds than others.
Mm-hmm.
And then you have rules and regulations, and in statute, what is the obligation of the state?
Mm-hmm.
how are we funding the medical records, for example? Is the state just buying them for everybody?
So we're using a federal grant, actually, so it wasn't.
Well, it just,
yeah.
But we had to do it together, and it's coming from the state, so we have to lead at the state level.
Yes, and we had to get those buy-in from the locals that they were, and it took a minute, right? No one wants to change what they're doing. So you're telling someone to get rid of their electronic health record system and totally switch to a new one. You know, I mean, it's for the greater good. I think it'll be great consistency-wise if a patient can go, you know, if they move across the state to another Georgia county, their record should be able to just be transferred.
The other part of where I was going, is there a way that we can make them accept these changes? Or will the local boards be able to say, no, I don't want these electric records? Again, I don't know how strong our coordination and our level of responsibility at the state level is.
I think as far as the electronic health records go, there's consensus among everyone that we're all moving in this direction. We haven't had pushback on that right now. So if we do, I'll let you know.
Are there any other questions?
I have one. So there are multiple districts, but each county in those districts kind of make their own decisions, is what I'm hearing?
Yeah, so it can be challenging. So the district is actually an entity of the state, but the individual county boards of health are independently, locally controlled. When the legislature funds the county health departments, they sign a contract with the state and agree to provide those core services I have listed. So that brings some consistency, and there are things added in there, you know, you have to abide by the governor's ethics orders or things like that. So that contract can help drive some consistency, but it certainly can't take into account every nuanced situation in that contract. But yes, the local boards do drive some of the direction as far as what services are delivered, and especially if they're putting money where their mouth is and are willing to fund it locally, then that's certainly something that, you know, can drive their decision making there.
Okay, thank you so much.
Thank you.
So I want to thank everybody for attending today. Our next meeting is going to be on the 23rd of September. That happens to be my anniversary, so there'd be no other place I would rather be than with all of you again. Members, you'll receive details through email, so watch out for that. Also, Leo Chansey will be sending all the presentations from today, so look for those as well. Please remember to check your inbox for those files, and also report your mileage and all the details directly to Carmen Sanchez. I want to thank Georgia Southern for allowing us to come today, for hosting us, with the excellent staff, Rebecca Riles and the East Georgia Healthcare Center for their contributions, and for all of our presenters today. I feel like we all know a little bit more about what we're talking about. Thank you so much.